طيب, Assalamu alaikum. Good morning, everyone. It is a real pleasure to meet with you all again on this platform, the Sudanese Society of Breast Imaging and Women Health, where we do gather together to discuss and share our knowledge and experience in the management of breast disease. And on this particular symposium, we focus on the theme of early breast cancer, disease and management. And this is the second day of symposium. We will be discussing the surgical and oncological aspects of early breast cancer. Good. So we started with Mr. Omar Al-Farouq, who is Associate Professor of Surgery, is also faculty in the School of Medicine at University of Khartoum. And in addition to that, he is a head department of surgical department in Ssbiwh University Hospital. Currently, he's practicing in the UAE, and he will be sharing with us and insight on the techniques of detecting axillary lymph nodes in early breast cancer, with more emphasis on sound trial. So thank you, Mr. Omar.
Thank you very much, Dr. Tamado, for this kind presentation. First, I would like to thank the organizing committee for giving me the chance to talk in this very prestigious symposium, and hopefully I will be useful presenting these two lectures. We'll start. بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيدنا محمد وآله وصحبه أجمعين. Dear colleagues, let me see if we can move this. Okay, so my first presentation will be about the sound trial, which is the sentinel node versus observation after axillary ultrasound. My name is Omar Al-Farouq. I'm a consultant surgeon, breast and colorectal. So to start with, I will give just a background and rationale of this lecture. Historically, axillary lymph nodes dissection is a standard, and as we all know, it is associated with high morbidity. And sentinel lymph node biopsy reduce the morbidity and become the standard for early breast cancer management nowadays. So there is landmarks trial, randomized control trial like the ACOCOSG, Z001, and the IBCSG and the Ambrose, and they all show no survival benefit from the axillary lymph node dissection. The question is sentinel lymph node still necessary in a small nodal negative cancer with negative axillary ultrasound? This is a $1 million question. Yes, I will say yes, but we'll see later. Okay, so the landmark control trials in the axillary management of breast cancer. I'll first talk about the ACOSG, the 011. The population, women with T1, T2 invasive breast cancer, clinically nodal negative, and they undergoing breast conservative surgery plus radiotherapy. And the intervention is either to do sentinel lymph node biopsy alone or sentinel lymph node plus axillary dissection if the patient have 1 to 2 positive sentinel lymph nodes. And the finding, they find there is no difference in overall survival and disease-free survival, and regional recurrence is very low if you do just sentinel lymph node alone. Very interesting. The conclusion, axillary lymph node dissection can be omitted in selected patient, and yeah, you have to do a rigorous selection to do that. Then we have the ABCSG trial, and the population, they are clinically nodal negative with micrometastasis. They have in the sentinel lymph node, they have micrometastasis. And the intervention was sentinel lymph nodes alone or sentinel lymph node, and if there is micrometastasis, to do axillary lymph node dissection. And the findings, there is no difference in disease-free survival, overall survival, and there is reduced morbidity with sentinel lymph node alone. So in conclusion, again, axillary lymph node dissection not beneficial in micrometastasis disease. The AMROS is the population invasive breast cancer with positive sentinel lymph node, and the intervention either to do, if you have positive sentinel lymph node, either to do axillary lymph node dissection or axillary radiotherapy. And the finding, they find there no different in overall survival or disease-free survival. And radiotherapy has less cases of lymphedema, so it is safer to do it with a positive sentinel lymph node. In conclusion of that AMROS trial is the radiotherapy is an effective and less morbid alternative to axillary lymph node dissection. This is just a comparison for the three trials. So, what is a sound trial? A rationale behind the sound trial is to see if sentinel lymph node biopsies, first, sentinel lymph node biopsy is standard for axillary staging in early breast cancer. It provides prognostic information, but no proven therapeutic benefit yet. So the sound trial is aimed to test omission of sentinel lymph node biopsy in small nodal negative cancers. And the objective was, primary objective is to test if omission of sentinel lymph node biopsy is non-inferior to sentinel lymph biopsy in term of 5-year distant disease-free survival. This is the primary objective. There is secondary objective is to check the disease-free survival, overall survival, axillary recurrence, and adjunct therapy recommendations. It is a phase 3 multicentric non-inferiority randomized control trial. The population with women with invasive breast cancer less than 2 centimeters, so it's T1 basically. They are testing clinically nodal negative and the negative axillary ultrasound. So clinically and proven by ultrasound, they have negative axilla. The randomization was 1-to-1, and the performance 18 hospitals in Italy, Spain, Switzerland, and Chile. Follow up for 5 to 7 years. The eligibility, the inclusion criteria is important. Tumor, let's say, T1, negative axillary ultrasound. And if the axillary nodes are in doubt, they do a fine needle. And then they do breast conservative treatment and radiotherapy later. The total enrolled was 1,463, and the analyzed one is 1,405. There is 58 patient discontinuous, and the analysis was done for the intention to treat principle. The baseline characteristic of the patient, they are median age 60 years old, and medium tumor size 1.1, so they are very low risk tumor. ER positive, HER2 negative, around 93, and sentinel lymph node arm, they had about 13.7 nodal metastasis when they did the sentinel. So the adjuncts therapy, hormonal therapy, was given almost the same for both arms, and the chemotherapy again for about 20% of patients in both arms, and radiotherapy is given to almost everyone in both arms. Trastuzumab in both 6.6. So the survival, they found that the 5-year survival, distant disease-free survival for both arms is almost equal, 97, 98. Even better in the non-surgery group. 5-year survival, again the same, there's no statistically significant difference, both arms, and the 5 years overall survival, again the same. The recurrence, axillary recurrence, 0.4 in both groups, and distant metastasis 1.8 to 2, which is same in both groups. and locoregional relapse is almost the same. So there is no, in conclusion, there is no significant difference if in this very low risk groups you omit the sentinel lymph node biopsy. Omission of sentinel node is safe for low risk patient, as we say. Equivalent outcome in survival and recurrence outcome compared with sentinel lymph nodes. It avoids the morbidity, less lymphedema, improve the arm function, treatment decisions guided by tumor biology. Um, Although, as I said before, auxiliary information is still important. If we take younger, because of this cohort, they take patients, the median age is around 60. But if you want to apply this for younger population, yeah, still you cannot apply this because younger premenopausal women, as shown in the Bounder trial, still you need the auxiliary information for decision making, and the also in patient who is ER positive, younger age group, to decide about the endocrine therapy decision. HER2 or table negative cancer also to decide about systemic therapy and radiation planning. Still, this information is needed. So I wouldn't omit the auxiliary sentinel node biopsy. So, when auxiliary surgery remain relevant, younger patient, less than 50, chemo decision tied to nodal status, high-grade aggressive tumor, nodal information may guide escalation of the treatment, hair positive, triple negative cancer, nodal staging inform systemic therapy. And radiation planning, nodal field adapted if nodal is positive. So, a limitation of this trial was that the trial population is, as we say, is a low risk patient, older postmenopausal women with T1 tumor. The median follow-up is 6 years, and as we know, the ER positive tumor, the recurrence happens a bit late, and it's not powered for detailed treatment differences, and it is the late trial registration because this trial is done early and they registered the trial in 2024. But in all of this, we know that it supports the deceleration of auxiliary management, may influence guidelines on mid-sentinel lymph node when nodal information does not alter the therapy, and could reduce the cost and morbidity of this patient. It is aligned with the choosing wisely recommendation in most of the cancer, especially the breast cancers. This finished my first presentation. If you have any questions or you want to leave the question to the end of the second lecture, because it is again going to see the same theme.
All right, if there is no questions at the moment, Mr. Omar, we can continue with the second presentation.
Okay, thank you very much. So management of axilla, it is a very controversial issue, but I think soon people will know that we have to do less is more, as we talked before. So the recent ongoing or established recent trials for the axilla, as we say, shift from extensive axillary surgery to deceleration. Early landmark trial, the one we spoke about, and then the goal is to reduce morbidity while maintaining oncological safety. This is very important concept. This is the glossary of my presentation. Sentinel lymph node biopsy is a sample of first draining nodes. Axillary lymph node dissection is the axillary lymph node dissection level 1 or 2, sometimes 3. Regional nodal irradiation, RNI, which means the axilla, supraclavicular, infraclavicular, internal mammary nodes. and YP and 0, that there is no residual disease after neoadjuvant therapy. This is by pathological confirmation when we mention this term. TAD is targeted axillary dissection, and with that we mean removal of the clip node plus the sentinel node biopsy. So, what trials we know about regarding the axilla? There is trial number one looking at omission of the sentinel lymph node biopsy. Okay, and they are done in clinically nodal negative and the upfront surgery. So omission of sentinel lymph node biopsy. What trial? We have the Inthema, in which they say no, they put again two arms, no sentinel lymph node versus sentinel lymph node biopsy. In clinically node negative, confirmed by ultrasound, but unlike the sound trial, they included more high risk patients. So they get T1, T2, and they recruited also younger population. So it is more relevant than the sound trials. And the outcome that they found that the invasive disease-free survival at 6 years is almost the same. If you have clinically negative ultrasound, negative axillary ultrasound, then you do sentinel in patient, and another patient you don't. You just do surgery and radiotherapy. The sound trial we talked about, there is no axillary surgery versus sentinel lymph node biopsy, but they did that for T1 only tumor and the low risk group. So this is the two trials about omission of the sentinel lymph node biopsy. Outcome, there is no different 5-year distance-free survival, rare axillary recurrence. If we have trial about sentinel lymph node positive after surgery, if you did the surgery and you find that the sentinel lymph node is positive, what trial is looking into that? We have the SINO-MAC. They compare if the sentinel lymph node is positive, you do no axillary dissection versus you do axillary dissection, and in both you do radiotherapy. And those with, if you have like the sentinel of 1 to 2 lymph node positive, they group no axillary lymph node dissection versus axillary lymph node dissection. And they found that it is non-inferior, recurrence-free survival, less lymphedema, and they are the same. So even with the positive axillary lymph nodes, if you give only radiotherapy, is comparable to doing axillary lymph node. Another one, the post-node. This is an ongoing trial. It will be very interesting to know the result. They're going to finish at the end of this year. Most probably they'll publish the result at winter this year. No further auxiliary treatment, no radiotherapy. If you find that only 1 to 2 lymph node, they divide them into patients who don't have any auxiliary further surgery or radiotherapy versus patient will have, if the positive node 1 to 2, they have axillary lymph node dissection and another arm radiotherapy. And they want to compare all these arms. The outcome is the regional recurrence, survival, and as I told you, this will be very interesting to know the result of this trial. So if we have clinically node positive cancer, clinically positive and ultrasound positive, what trial? We have the taxes and the taxes. It is also again in ongoing trial. It check against the targeted axillary lymph node dissection plus radiotherapy versus complete axillary lymph node dissection. And the TAD, they mean removal of the clipped node plus the suspicious node no full clearance. So they are comparing TAD with complete axillary clearance in nodal positive disease, and they are checking for the outcome is disease-free survival and quality of life, overall survival and lymphedema. And still, again, it is going to be very interesting to see the result of this trial. The other trial after neoadjuvant, if you have the patient who's clinically nodal positive had neoadjuvant treatment, and then you did the sentinel lymph node biopsy, and you find that they're negative by ultrasound and sentinel lymph node biopsy, like the NSAPP, they find that omitting regional node irradiation versus regional node irradiation in clinically positive, which become negative. If we have the nodal negative after the new adjuvant, do we need to give radiotherapy or not? An outcome, they find that there is no difference in invasive recurrent free survival after if you give radiotherapy or not. Very interesting, very interesting. So they found that the regional recurrence is less than 2% in both arms. So inclusion and conclusion regional lymph node irradiation can be omitted in pathologically negative after neoadjuvant treatment. So if you other trials are done after you do the neoadjuvant, and then you find that in the biopsy that the nodes are still negative. Do we give auxiliary radiotherapy or do dissection, full dissection after the neoadjuvant if the nodes are still positive? And the outcome was invasive disease-free survival, and the hypothesis that radiotherapy will be non-inferior, avoiding morbidity of the auxiliary lymph node dissection. And still the Alliance trial is going to see if we just need to do radiotherapy or full auxiliary lymph node dissection. So the targeted auxiliary dissection, we have the Exana trial showing that sentinel lymph node biopsy targeted auxiliary dissection, which means the clipped node, versus auxiliary lymph node dissection after neoadjuvant. And the outcome was the auxiliary recurrent survival morbidity. And the early data show the false negative node is less than 10% if the clipped node and sentinel node is retrieved. They aim to define long-term safety of avoiding auxiliary lymph nodes in neoadjuvant chemotherapy patients. This is again another trial awaiting for the results. So the paradigm is to surgery in selected omission were safe, radiotherapy tailored not blanket, systemic therapy and imaging guide auxiliary management. Overall trend is less surgery, more precision. The take home practical takeaway messages is omit sentinel lymph node is safe in small ultrasound negative tumor like the sound and eczema trials. 1 to 2 positive sentinel node, you can omit auxiliary lymph node dissection, the Sonomac trial. Post neoadjuvant, pathologically negative, you can omit radiotherapy, the B51 trial. Residual node post neoadjuvant, auxiliary lymph node dissection or radiotherapy, still awaiting the results. And then the clinically positive nodes, the taxostomy may allow auxiliary lymph node dissection replacement with radiotherapy. Be interesting to know this result of this trial. And the TAD is visible and validation is ongoing, the target auxiliary lymph node dissection, apart from the total nodal dissection. And the theme is deceleration with safety, very important. Okay, uh, are we good?
Yeah, we're good. Thank you,
Okay,
Mr. Omar.
okay. So we'll just continue. I don't have, I just have like five to, not five, about 10 slides to go. So
Okay, that's all right.
management of the axilla. Management of the axilla has evolved in the last decade. Axillary nodal metastasis is a significant prognostic factor in breast cancer, influencing surgical and adjuvant treatment. While the surgical approach to the axilla has become increasingly conservative, the optimal management of the axilla continues to be controversial, as we all know. I think by the end of the next 2 years, when the result of all these trials come out, we will have really, I think people will consolidate the management of axilla in a proper way. And I believe that will be going to be very minimal you will do to the axilla. So traditionally, all patients proceed to axillary lymph node dissection irrespective of nodal status. But axillary lymph node dissection is associated with significant morbidity, including lymphedema, impaired shoulder movement, and arm sensation, resulting in considering impact on quality of life. Um, it's just very early result of false negative when we do the axilla sentinel. If we do sentinel lymph node alone, the false negative is 10%. If you do targeted lymph node dissection alone, the again 4.6. If you do them together, sentinel, the false negative goes down to 1.4. Very interesting. That's why I mean targeted lymph node dissection nowadays is gaining popularity. So the NCCN key changes and recommendations is this de-escalation of the axillary surgery. Guidelines continue to move away from routine axillary lymph node dissection. Sentinel lymph node is a standard. For clinically nodal negative patients, sentinel node is a recommended approach for assessing axilla. Limited axillary node dissection. Extensive positive sentinel node finding, more than 2 or 3 nodes, depending on the surgical approach or when axillary status is impact is important. We do the axillary lymph node dissection. If the impact of the new adjuvant therapy is important, again, axillary lymph node dissection is important. At the end, regional nodal irradiation may be used in conjunction with sentinel lymph node in certain patient group as a supplement to avoid more extensive surgery. This is the latest NCCN guidelines. But as I told you, most probably in the next 2 years, those will be changing dramatically. So, sentinel lymph node mapping. Techniques, we have radio tracer, blue dye, endocyanin green, magnetic, contrast enhanced ultrasound, OSNA. All these are ways to map the nodes. We have the dual tracer when we use technetium radioisotope plus the dye, either ICGs or blue dye, is a standard nowadays. ICG avoid skin staining, real-time visualization. The magnet tracers are useful when nuclear medicine is limited, and the contrast enhanced ultrasound is visible, but it is operator dependent, and it's still evolving. So sentinel lymph node using the radio tracer is we inject that peri or subareolar, peritumoral or intradermal. A timing short protocol is 2 to 6 hours, or the long protocol is a day before surgery. A detection rate is more than 95. It's the dual. If you use a dual technique, it's more than 98. Advantage is highly accurate. Disadvantage is require nuclear medicine at cost moderate to high. اللوجيستيك والراديو ايسوتوبز والحاجات دي make the cost moderate to high. Then, and you have to have special equipment, expensive to start with, but if you purchase that, I mean, the cost will go down in the next years. Blue dye injection is peri or intradermal, peritumoral, intraoperative 10 to 30 minutes before the incision. Detection rate is 80 to 85 if it's used alone. Advantage is immediate, no special equipment, very cheap, but cost is low. Disadvantage, they might cause allergic reaction very, very, very low, 1 to 2%, and tattooing. Then we have the indocyanine green. Injection is subdermal, superior, intraoperative just before the incision. Detection rate is more than 95, similar to radio tracer. Advantage is real-time visualization, avoid tattooing. Disadvantage required a special camera and it is has a limited penetration, although it's not that big problem. Cost is moderate. Dye is inexpensive, but the equipment is expensive. الكاميرا والحاجات. This is an indocyanine with a special camera. A sentinel lymph node using the supraparamagnetic ion site is usually the injection is subareolar, a timing flexible, days to weeks before surgery. Detection rate 95 to 97. Is not inferior to the radio tracer. Advantage, avoid isotope, flexible scheduling. A disadvantage is skin staining والحاجة اللي كلنا عارفينها MRI artifact والdevice cost. Again, the cost is moderate to high. You need special devices and special tracers, magnetic. Contrast enhanced ultrasound is they use micro bubbles, contrast agent, sulfur hexafluoride micro bubbles injected intradermally or peritumorally. A micro bubble travel to the lymphatic sentinel node, which can be then visualized by a dynamic ultrasound. It is, as I say, peritumoral, periareolar micro bubbles injection timing. Immediately before surgery, detection rate is 80 to 90. Advantage, no radiation, preoperative localization. Disadvantage, operator dependent to limited adoption still till now. And it is the cost is moderate, need a contrast and operator experience. This is how they see the one with the dynamic ultrasound after injection of the micropubbles. So this is the timing and detection. Radio tracer 2 to 24 hours before surgery, 90%, 95% detection. Blue dye 80 to 85 detection. Idocyanine green intraoperative timing, it is more than 95th. Ssbiwh days to weeks and detection is for 95, 97. Contrast enhanced ultrasound immediate during surgery, detection is 80 to 90. Dual tracer is more than 98% detection. So, of technique of targeted lymph node localization, we have, if you want to localize the lymph node using the targeted lymph node localization technique, we have the visual techniques, which is by injecting charcoals with ultrasound. You inject charcoal into the suspicious lymph node, and then during the operation you will visually see those lymph nodes. Or you do the image guided techniques by putting clips or coils or wires with the ultrasound. And then we have the third one is the probe guided techniques. So this is a tattooing. You inject the charcoal into the nodes, and then during the surgery you will detect that visually. Clips, seeds, localization. You can put clips or seeds or probes, and then detect them during the surgery. And then the last one is a probe guided technique, where you put radioactive seeds, magnetic seeds, radar seeds, radio frequency identification tags all these are options for probe-guided techniques. So you can detect after you inserted these probes, you can detect them with special devices, either radioactive monitors, magnetic monitor, radar monitor, or radio frequency monitors. Okay, this is the radar monitor. So in conclusion, modern breast care, cancer care, less is more. Shift from radical intervention to minimally invasive evidence-based approach. Avoid overtreatment while maintaining ecological safety. Deceleration, shared decision making with the patient, clear communication of treatment intent and expected outcome, precision medicine and tailored therapies, and treatment according to the patient's profile and life goals. Thank you very much. Again, if you have any question, you're welcome to ask.
Thank you, Mr. Omar, for this brilliant presentation. Very informative and very thorough. So we can answer the questions now. I can't see any questions online. If any of the panel or the participants have question or points to add or discussion, they are welcome.
Okay.
All right, so it seems like there's no questions at the
Yeah,
moment.
thank you. Thank you very much,
Thank you,
Tamado,
Mr. Omar.
for actually, I want to thank you for organizing the surgical sessions before and having this very nice sequencing for the lectures, which made it very interesting to follow. Thank you.
Thank you, Mr. Omar. It's actually a teamwork. Me and my colleagues have been working on this together. So thank you so much for that.
You're welcome.
All right, so next will be myself. I'll be sharing with you insights and a brief discussion about the management of DCIS and the escalation of treatment and what the future might hold for us in downgrading or de-escalating the treatment of DCIS as an early stage of breast cancer. So, Mr. Omar, if you can stop sharing, they can
Yeah,
share my
okay.
slides, please.
Yeah.
Thank you. Okay, is that coming through clearly? Can you
Yeah.
see my slides clearly? All
Yeah.
right, good. Thank you. So I'm Dr. Tamada Osman. I'm a specialty doctor in breast surgery, currently practicing in the UK with a background of MD in general surgery. So during the next few minutes, I will be sharing with you a discussion about ductal carcinoma in situ, with special emphasis on the evolution and the de-escalation strategies in the management of DCIS. So I'll be discussing with you brief and basic concepts that will help us to better understand the DCIS as a disease, and also will be discussing the tools of evaluation and the workup that we do to reach this diagnosis. And then we'll be covering the current practice in the management and focusing on the future or the anticipated changes in the management of DCIS. All right, so basically the WHO defines ductal carcinoma in situ as neoplastic cells that are confined to the breast ducts without invading through the myoepithelial layer, that part with basement membrane is still confined. And there's always been that question of whether do we consider ductal carcinoma in situ as a precursor for invasion or not. And the answer of that is actually considered to be non-obligatory precursor, meaning not all ductal carcinoma in situ will eventually turn into or progress into invasion. Only 25 to 50% of cases will progress to form invasive disease as a natural history. And this progression is actually quite a complex process with multiple factors involved on it, including genetic factors and also other shared factors with the invasive disease itself. So, as an epidemiological background, the prevalence of ductal carcinoma in situ represents 20% of all breast cancer diagnoses globally, which indicates significant burden of this disease. And the mean age of diagnosing ductal carcinoma in situ is actually 10 years younger than the invasive disease. And the risk factors behind that are actually the same risk factors that causing invasive breast cancer will cause pre-invasive breast cancer. And that basically involve, for example, estrogen, prolonged exposure to estrogen, and family and hereditary factors in particular. Good. So to evaluate the disease and detect it, we need to consider the concept that DCIS is quite variable and heterogeneous disease. It does have variable presentations. The genetic makeup of it in form of mutations and changes happen at genetic level are quite variable. And also the biomarkers that we detect during evaluation, they do vary. So clinically, this is considered to be asymptomatic disease. Only 15% of patients present with the symptoms that indicate disease. The majority of cases will be detected during a screening mammogram. So the mammogram considered to be the gold standard or the main diagnostic modality in detecting DCIS, where we do see microclassifications being aligned in a form of like branching, linear branching or segmental pattern of classification, and that indicates high risk of malignancy when we see those pattern of classifications. Ultrasound is another useful modality where we can see hypoechoic masses or areas, and we can also see microclassifications. MRI is particularly important when we need to determine the extent of the disease and also when we deal with high-risk patients. So MRI would be a quite handy and quite useful tool in diagnosis of the disease. Okay, since we have seen that microclassification on the imaging and we took the biopsy, what do we look for at a histological level? Basically, we need to determine the architectural pattern of disease. Usually, it's being classified into five architectural patterns, either DCIS of chlamydia type or cribriform, or could be micropapillary or papillary or solid type. We do also look for the grades and classify it into high grade, intermediate, and low grade. In addition to that, we look for other biomarkers in immunohistochemistry or molecular tests, particularly looking for estrogen receptors and HER2 status of the disease. Then the treatment will be personalized and guided based on multiple factors. And the treatment of DCIS is usually multimodal form of treatment, involves surgical treatment, and then adjuvant radiotherapy and endocrine treatment. And the decision to use those modalities individually or together is really based on the individual risk of the patient. Good. So to guide the decision of treatment of DCIS, we do need to stratify the risk of the disease, whether are we dealing with a high-risk disease or a low-risk disease. And there's multiple factors we need to consider before we stratify the disease into those two risk categories. The first thing we consider is the age of the patient. So the younger the patient, the more risk is considered. And by risk, we mean the risk of progressing into invasive disease or risk of recurrence in the future. So the younger the patient, the high risk is considered. And the size of the tumor, the bigger the tumor, the more risk is involved in the disease. In addition to that, mass formation. If the patient presents with a mass from beginning, that would be considered as one of the high-risk features. Nuclear grade, the higher the grade, the presence of necrosis in the histopathology, those are also considered to be high-risk groups. They are not limited There's just examples of the factors that we consider before we stratify. Microenvironment has been particularly important field to focus on, and it's an area of researches at the moment where they do look for multiple biomarkers and multiple factors around the tumor itself as a microenvironment, they call it. And there is particular emphasis on the presence of lymphocytes around the malignant cells that would indicate a high-risk features. More likely, those cells will turn into like invasive disease in the future. So those factors together, in addition to other factors, would be used to stratify the disease into either high risk or low risk disease, and then the decision of treatment will be guided with this classification. Good. So surgery is the first modality of treatment and is the main and the standard treatment for treating DCIS, where we do aim to completely excise the disease with a clear margin while keeping the balance between this oncological safety and cosmetic outcomes. And we usually consider either mastectomy or breast conservation as approach, as a surgical approach. They both really give very comparable results. And actually, there's new emergent data showing that breast conservation gives better outcomes in terms of survival and quality of life. So we need to consider that when we make the decision. And because it's usually impalpable disease and asymptomatic, so localization is quite important when we consider breast conservation. Any modality or any form of localization will give comparable outcomes. The margin in DCIS is particularly important because in DCIS we aim for a wider margin. We aim for 2 millimeter margin, which is wider than the invasive disease. And that partially explained with the fact that the histopathologists find it quite challenging to determine the margin in DCIS because as nature, the disease tend to grow in patches. There is natural gaps between the malignant cells. And also because it does grow within the ducts tend to turn and branch. So it's quite difficult to follow under the microscope. So given a wider margin, we just give us more safety to not miss any cancer cells and reduce the chances of reoperation and re-excision of margins. Now, interestingly, there is an ongoing trial at the moment called the DISC trial, where they do investigate the outcomes of routinely doing 4-quadrant shave after excision. And they think that this will minimize the re-excision rates and also the rates of recurrence in the future. So it's quite interesting to follow as a trial and to see the outcome of it. It is still ongoing. Now, as part of the surgical treatment, we always need to consider the axilla as well. And we need to ask that question, do we need to operate in the axilla? Do we need to test the axillary lymph nodes through a sentinel lymph node or not? This is quite a valid question because we know the morbidity of any axillary surgery is quite significant. Even with a minimum dissection, with the high technologies, we still do cause significant morbidity. So the guideline really do recommend that with breast conservation, doing routine sentinel lymph node biopsy is not indicated because we can always go back and get the sentinel lymph node biopsy if we have an evidence of invasion in the final surgical specimen. However, if we do mastectomy, then it's not unreasonable to do sentinel lymph node biopsy on the same time because it's quite difficult to go back and do sentinel lymph node biopsy if we don't have the technology of MACTrace. So MACTrace is a new technology that help us to make that decision, and it's really help in reducing the chances of operating in the axilla unnecessarily. So MACTrace is considered to be a dual tracer, meaning it gives a visual indicator and sound as well in the machine help us detect the lymph node. It's basically contain very, very small, like a nanoparticle of super paramagnetic ion oxide. So basically like magnetic small particles that we inject in the breast, and they do migrate from the breast to the axilla and stay there for a few months. So we can inject it before the mastectomy and leave it in the axilla, and then we wait for the final surgical specimen outcome, whether there is invasive disease or not. If there's invasive disease, we can just go back directly and do the sentinel lymph node biopsy for those patients who has indication. And this will help us to save the unnecessarily or to reduce unnecessarily axillary surgeries and reducing the morbidity associated with it. And we know from the data that only 1 out of 6 patients will need sentinel lymph node biopsy at the end. So that will really save 5 patients out of those 6. So that's quite significant. Now, speaking about the feature and the de-escalation of treatment, and the basic concept of de-escalating the treatment of DCIS came from the discussion about, do we overtreat DCIS? Because we do deal with it basically as if it's invasive disease. And we know that DCIS is a non-killer. It doesn't kill patients. Patient can live the same years if they receive treatment or not. It's all about the recurrence and the burden of disease itself and the treatment that they go through. So dealing with a non-killer disease has made us question, do we need to consider different modalities and different forms of treatment? And here it came the concept of de-escalating the treatment of DCIS. And to make that decision, whether we de-escalate the treatment or not, we need to consider multiple factors. One of them is that risk stratification uh, to develop or to give like more personalized and more target treatment to that individual patient. At the moment, there is ongoing trials aiming to de-escalate the treatment of DCIS, mainly omitting surgery for patients who are considered to be low risk group of disease, and that based on that risk stratification system that we discussed earlier. So there is ongoing trials here in the UK, in the States, in Netherlands, and in Japan, where they do tend to not perform surgery for those patients with low risk disease and just put them under surveillance and see the outcome of that in long term, in few years from that time. Some of the trials give anti-estrogen treatment during the surveillance time. Others, they don't give anything, just monitor the patients and follow them up. So the recruitment had stopped in the UK and in the States. So now we're just waiting for the outcome of those trials, where in Netherlands and Japan, they're still recruiting patients. So it'll be quite interesting uh, trials to follow and see the result of it. At the moment, we keep the same practice. We do follow the guidelines, which recommend surgical excision of DCIS, uh, regardless of the category of the risk stratification. Good. Now, the second part of treatment is the adjuvant treatment, mainly radiotherapy. We know now from the data radiotherapy is quite important in reducing the chances of recurrence. In DCIS particularly, it reduced the chance of recurrence by 50%. And that outcome need to be our weight and judge against the side effects of radiotherapy as well. So in some particular group of patients, we can omit radiotherapy actually in selected group of patients. For example, senior ladies more than 70 years old with ER positive, and they will receive endocrine treatment. So it is not unreasonable to omit radiotherapy and not giving it to them and just give them endocrine treatment instead, just to minimize the side effects and the risk involved with radiotherapy. Because we know that radiotherapy carries potential side effects and morbidity on the short term and on the long term. And at the end, there is no survival benefit of it. It does reduce recurrence, but it doesn't reduce mortality. So that's quite important thing to consider as well when we make a decision regarding giving radiotherapy or not. To help us also make this decision regarding radiotherapy, there is a new predictive tools that help us in making that decision more personalized and precise decisions. We use what we called DCICON radiotherapy signature, which is basically a diagnostic tool or predictive tool that consider multiple factors to stratify patient into high risk and low risk group again, and whether do those patients need radiotherapy or not. So this tool will help us to deliver more personalized treatment to that particular patient. Another adjuvant treatment that we can give for DCIS is endocrine treatment and hormonal treatment. Tamoxifen is a standard to be used for 5 years for those with ER positive DCIS, And the trials and the data has showed uh, significant benefit from using this treatment. AI aromatase inhibitors can also be used for postmenopausal ladies to reduce the chance of recurrence. Now, even beyond that, there's more advances in the treatment of DCIS. At the moment, there is trials and research is ongoing, uh, which involve using vaccines in treating DCIS. And the concept behind this vaccine is basically some form of neoadjuvant treatment, where we do give anti-HER2 targeted treatment that will induce immunological response inside the body through dendritic cells, which will target the HER2 expressed in the tumor cells, destroying it. And the aim of that is to get what we call complete pathological response at the end. So it's still ongoing, it's still under study, and it's also quite interesting to follow and see the outcome of it. It's again help us to de-escalate the treatment of uh, DCIS and omitting the surgical treatment. Now, at the prognosis or final outcome, when we do counsel patients about the DCIS, we need to reassure them that the disease is a non-killer in general, and the outcome of it in long term, like in 20 years, the mortality rate is just 3%, which is very good outcome. And also patients need to know that they will be under surveillance after treatment just to detect any early signs of recurrence, that they will be having mammograms annually for few years, depending on the protocol that they follow. And also they will have regular clinical assessment um, to be examined and assessed clinically as well. So that also will help to detect any early signs of disease. Good. So that's it for the discussion of DCIS. So the take-home messages is that when we deal with DCIS at an early stage of breast cancer, we need to consider the fact that it is a heterogeneous disease, has quite variable clinical presentations, quite variable biological features and genetic makeup. And when we do decide about the treatment, we need to guide that uh, treatment decision with the risk stratification system, where we do classify patient into high risk and low risk group, and then we deliver the treatment based on that. And the main aim of that is just to give more targeted treatment and not to overtreat patients. We need to consider that auxiliary surgery is not recommended in DCIS unless we're doing mastectomy and there's no MAC available um, in the area that we're practicing. Surgically, we aim for 2 millimeter margins, which is wider than the invasive. And whenever we endowed clinically, intraoperatively, we can take cavity shape. That will also reduce the chances of going back for the excision. And as de-escalation approaches and concepts, we do look for the outcomes of the trial that they do omit the surgical treatment for low-risk patients and just put them under surveillance, which would be a quite a good um, advance or step in reducing unnecessary surgeries for this particular group of patients. And thank you. Thank you so much.
Thank you, Tamado. Very, very comprehensive and very informative lecture. Uh, Question.
Yeah.
For the radiotherapy decision, is it important to know, I mean, for the low risk and high risk for the decision of radiotherapy, is it still
Yeah.
applicable if you know the patient is low risk, you don't give radiotherapy if it is high risk according to the proliferation and the number of DCIs? So the pathology, is it still applicable or?
Yeah, like at the moment in the current practice, there is some cases where we can omit giving radiotherapy to them after discussion in the MDT for sure. And for example, like those senior patients, more than 70 with ER positive, it is quite unreasonable. It is reasonable and not unreasonable to omit radiotherapy on those particular group of patients. And also, when we discuss it with the patient in the counseling, when we tell them that it's not going to reduce your chance, it's not going to add any survival advantage, it's all about recurrence advantage. patient might choose not to have it,
Yeah.
it is still reasonable to have that discussion and make that decision. But I can also listen to my senior colleague in the panel if they have different practice in their field.
I think the tumor grading and thing it take part in deciding
Exactly,
if
exactly.
if you need a radiotherapy or not. This
Yes,
is
yes,
part of classifying it into low risk and high risk. Okay.
exactly. Yes. All right. Any questions from the panel? Any points that we need to discuss?
Thank you very much for Dr. Omar and Dr. Tamadwar, and for these amazing lectures, very informative.
Thank you, Dr. Bob.
Especially Dr. Tamadwar, the area of my interest.
Yeah.
I have discussed it last week. I was
All
looking
right.
for
Okay.
you. I was looking for you, yani, to comment or to
Oh, I'm sorry. I did
interfere,
attend
but
that
you
part.
are
I did join, but just for a very short time. I couldn't really continue in on the session. So sorry for that.
yes, yes. But yes, continue regard. I'm not going to comment on the treatment or selection of treatment, but regarding the, nowadays, uh, in the recent literature, the
Yeah.
role of radiology competing the pathology in uh, predicting the aggressiveness and the behavior of the DCIS
All
to
right.
predict the upstaging or the upstage of or upgrades of DCIS. And even from imaging, we can suggest if there is a possibility of associated microinvasion or
Oh,
even not only invasion, even microinvasions.
that's very
Okay,
interesting.
or
That's really
we
interesting.
can, yes, yes, and we can suggest if it is low or high grade DCIS
All right.
before
Yeah.
pathology, and we can correlate, and even we can suggest this DCIS is combination of both low and high grade types of, and furthermore, beyond that, we can suggest from radiology, is it a ductal type or is it an acinar type?
Oh, amazing. Amazing.
Arises from the acinar, which is more, having more favorable prognosis, that usually representing grade 1 and grade 2.
Yeah.
We correlate with the pathological grading more than the types of the DCIS pathology on the pathology. More than the comedo types and solid and these, the
Yeah.
correlation a little bit weak with the grading, but there are uh, not ultrasound, imaging,
Yeah.
ultrasound, mammography, and MRI, okay, and even contrast enhanced mammography and new modalities,
Yeah.
uh, biomarkers that can predict the types and the grading and the behavior of DCIs.
Amazing. This is really interesting, Dr. Bob. Really interesting because we
Yeah.
know imaging as a diagnostic tool is a non-invasive, so it will always be superior to the other invasive tools. So if you can categorize patients into like high risk and low risk based just on the imaging feature, that would be really superior and would be a very good addition
Yeah,
in the
this is a recent trend,
evaluation of
actually.
disease.
Yes, this
Yeah.
is a recent trend. This is a
No, this is
recent
quite
trend.
interesting.
Now,
Yeah.
yeah,
Thank
this is
you.
the recent trend nowadays, talking
Yeah.
about the new classifications of the breast cancers based on their origins.
All
Okay,
right. Okay. Is that an
from either
AI-based tool, Dr. Bob, or it,
not only AI. AI is
okay.
supportive, not
Okay.
AI
Yeah.
is supportive. Radiological analysis by the
Yeah.
radiologist himself, by expert
All right.
breast radiologist.
Yeah.
Okay, we have discussed a lot of cases. You can review the lecture. You can see how imaging can predict.
Sure, that would
Very
be really quite
interesting.
interesting area to explore.
Yeah, very interesting. Very interesting. From imaging to tell this is could be arises from uh, TDLUs, and therefore it would not be above grade 2. And even from imaging, we can tell this is probably grade 1 or
Yeah.
grade 2 because arises from the TDLU. And from imaging, we can say, no, this is a ductal disease, so this is grade 3. Before just pathology for confirmation.
No, that really interesting. That interesting. Thank you, Ssbiwh. Thank you for sharing that part.
Okay, no thanks for my duty. You are welcome
Right.
always. You are always welcome.
All right. Then, any further comments or discussions from participants? All right. So we can go ahead with presentations. So the next, our next presenter will be Mr. Hussein Ali. We should have Mr. Umar Abdul Hamid next, but unfortunately, he did apologize from presenting his session due to health issues. So, يعني إن شاء الله ربنا يشفيه. So the next presenter would be Mr. Hussein Ali. He is associate doctor in breast surgery practicing here in the UK with the background of MD in general surgery and also FRCS and European board in breast surgery. So Mr. Hussein will be discussing with us his topic about neoadjuvant endocrine treatment. So thank you, Mr. Hussein. All right, so it seems like Hussein is not on the meeting yet. Maybe he's not ready because we're running a bit ahead of time. So I can see Miss Muna Suleiman. Muna, are you ready to present your topic next?
Or you can continue discussion until they will be ready, if they are not ready.
Okay, so we can discuss further about the axillary detection techniques and the DCIS disease in general. And
Yeah.
Okay, greetings.
Muna is not Ara.
Uh,
Aida, okay.
hello, Ms. Aida.
Hello. Very nice two presentations, axillary dissection, axillary lymph node mapping and dissection, and oncoplast and ductal carcinoma in situ. Very well presented and instructed. Very interested what Dr. Rabab mentioned about can recognize the type, the histological type of DCIS from radiology. Radiology is going far, very far. So it's very interesting. And I do agree with Mr. Omar that axillary surgery is going less and less. And the most important thing is not to combine surgery with radiotherapy, and this is going to cause problems. But we need early detection to detect cases early, and we need to use the methods of mapping and methods of interoperative marking of the sentinel lymph nodes. So thank you both of your presentations. Thank you.
Thank you, Anna.
Thank you, Ms. Aida. Thank you for your comment and your insights as well. So Mr. Hussein will be joining us in 10 minutes from now, and Ms. Muna Suleiman actually should not radiate, so we might just need to have a bit of break.
Yeah,
Thank you.
okay.
Okay, so our next speaker will be Mr. Hussein Ali, who is a senior oncoplastic breast surgery fellow practicing in the UK, with a background of MD in general surgery and FRCS qualification in addition to the European breast board exam. So Mr. Hussein will be sharing with us the topic of neoadjuvant endocrine treatment in early breast cancer. Thank you, Mr. Hussein.
Good afternoon. Thank you for inviting me to participate in this MDT and symposium. Glad to be
Mr. Hussein, if you can get the mic more close, please, that would be better.
Is it clear now?
Yes, it's much better now. Thank you.
Much better. And can you see my slides?
Yes, we can.
Okay, so I have no conflict of interest to disclose, and I would start by introducing the importance of neoadjuvant endocrine treatment within the context of early breast cancer. And generally speaking, it is not a new concept, but I believe it is underused, specifically in our situation back home. It is well-established practice within the UK, and there is evidence to support it, but I believe it's still underused even here in the UK. So a bit of a background about the endocrine treatment in general. As I said, endocrine treatment as adjuvant treatment is as early as late 60s, early 70s. And even before that, there is evidence of oophorectomy to suppress estrogen, and there is clear evidence that works to control the cancer, whether it is locally advanced or adjuvant treatment after removing the cancer. But the idea of upfront endocrine treatment, like neoadjuvant chemotherapy, which is well established and known, started early in 1980s. And the first time they started it, it was for frail women to test whether they can control the cancer rather than facilitating breast conserving treatment. And it was tamoxifen, as it was the only endocrine treatment available there and then. And then in early 90s, the idea of neoadjuvant began as a way to avoid mastectomy. So it is not new, it is backdated to early 90s. And early 2000s, when we had the last and the third generation of aromatase inhibitor, which is much better in terms of outcome and avoidance of mastectomy in comparison to tamoxifen. Okay. So the first generation of AIs also started as 1980s, and at that time to treat a plethora of illnesses, not solely for advanced breast cancer, like epilepsy, prostate cancer, Cushing syndrome, and it is usually given association to high dose of steroids with poor selectivity and huge side effects profile. Then in early 90s, we had the second generation of aromatase inhibitors, better selectivity and less side effect and more efficiency. And they prevail until early 90s, early 2000, when we get the final and the third generation aromatase inhibitors. So currently, we are using the third generation aromatase inhibitors, and they are two categories: the non-steroidal, and they are very selective and reversible, namely the anastrozole and letrozole, and the steroidal one, which is irreversible, AI, which is exemestane. So to compare the three in terms of efficacy, the letrozole is more potent than anastrozole and exemestane as estrogen suppressor. But that is not clinically proven that letrozole is superior to exemestane or anastrozole in the clinical setting. And there is no solid evidence with head-to-head comparison between the three. So when we select which one to use, rather than rely solely on just anastrozole or letrozole without clinical evidence to say letrozole is superior or not, you need to factor in the profile of side effects and your patient to choose which one to use. So generally speaking, letrozole and anastrozole are non-steroidal, and they are more common to cause joints and bone aches and hot flushes. So if you have a patient with rheumatoid arthritis or any sort of joint aches, primarily it's better to avoid anastrozole and letrozole. And for the steroidal exemestane, weight gain is the most obvious problem. So if you have an obese patient or a diabetic patient, it's better to avoid using exemestane. And at the same time, if there is joint ache or perimenopausal symptoms, it's better to use it because it is better in this setting. So we need to understand the difference, and you tailor according to the patient profile. So why we use neoadjuvant endocrine treatment? So after knowing a little bit of a background about the efficacy and the history behind them, why we need to use neoadjuvant endocrine treatment and why I said it is underused. So you can use it if the patient is frail and will never stand any surgical intervention. But we call it primary endocrine treatment in that setting, and it is a different story, and I'm not going to talk about it. However, when we say neoadjuvant, that means it precedes surgery. That means we're expecting to have some sort of surgical intervention at some point, and we are using this neoadjuvant endocrine treatment to facilitate that type of surgery or to make it less invasive. We can use it also temporarily. For example, if you have a patient with a recent MI, very suitable to go straight away for a lumpectomy and sentinel lymph node biopsy, but not anesthetically fit. You can put them on neoadjuvant endocrine treatment until after 6 months or 9 months, you get the clearance from the cardiology and the anesthetic team, and then you proceed with surgery. Or somebody with transient social issues, they cannot go for surgery at the moment for any reason. For example, somebody, especially in Sudan, waiting to go to Hajj for 20 years. And just 1 month before that, they got a diagnosis of early breast cancer, and they don't want to sacrifice that very holy journey. You can just put them in a neoadjuvant endocrine treatment, let them complete that journey, and come back and do the surgery safely. Or, very useful tool, we used it during COVID, because people are avoiding hospitals and avoiding going under general anesthesia to avoid contracting COVID. And that's a very safe way to put them on neoadjuvant endocrine treatment until we are in a better position to operate on them. And the main indication is to avoid mastectomy. So if I have a patient with 3-4 centimeter lump in a small breast like AB cup bra, and they would like to avoid a mastectomy, it is a very useful tool to use it to shrink the cancer, to avoid mastectomy, and to facilitate breast conserving surgery. And even if you are going for a mastectomy, sometimes you can have a locally advanced cancer. I know it is out of the scope of this symposium to speak about advanced breast cancer, but by the by, if you have a T4 ABC, stick to the skin or to the chest wall, you can use neoadjuvant endocrine treatment to make it operable and to facilitate mastectomy. And to a lesser degree, if the patient has 1 up to 3 positive lymph nodes, biopsy proven, abnormal in the mammogram and ultrasound, and they are trying to avoid axillary node clearance, you can start them on neoadjuvant endocrine treatment and monitor the response. You might end up with a good response to avoid axillary clearance and end up doing targeted axillary dissection rather than clearance. It is not usually used, but it can be. So out of all these, we can use the temporal, social, or medical issues and to avoid mastectomy as the main target for this type of treatment. So, for who? Is it suitable for any patient? The answer is absolutely no. You need at least ER positive, and if we are using already score, to be minimum of 3 or more out of 8. So if it is 1 or 2 or ER negative, there is no way we can use it. And it must be HER2 negative. Even if it is 8, and the HER2 is positive, is still no place to use neoadjuvant endocrine treatment. But there is a bridging use. I will come back to it at one of the coming slides. If the estrogen is positive, HER2 negative, we need to look at the PR, which is the progesterone. And if it is negative or positive, you can still use aromatase inhibitors. But if you have PR negative, avoid tamoxifen, as the outcome will not be favorable. So we need ER positive, HER2 negative, and if the patient is premenopausal and we are considering tamoxifen, it must be progesterone receptor positive. We can use it in all T stages from T1 to T4, including A, B, and C, and obviously T4D, inflammatory cancer. That's a different story. We can use it for node negative, or if we have anything between 1 and 3 node positive in the axilla, and obviously it must be M0, and we can use it in all grades, including grade 1, 2, and 3. We can use it for any invasive cancer, including ductal and lobular, but not for a DCIS. I have said earlier, you can use it in premenopausal and postmenopausal. However, the established and the standard treatment is to use it mainly for postmenopausal and to avoid doing it in premenopausal ladies. But if you consider it in selected cases, you need to consider using AI with a Zoladex to temporarily render the patient postmenopausal and use AI, and better to avoid tamoxifen because it is not as potent or effective like AI. So what do we need to do before starting any patient in neoadjuvant endocrine treatment? After, obviously, explaining the rationale, explaining the diagnosis, however, we need to mark the cancer with a marker clip, and I emphasize it by putting it as number 1, number 2, and number 3. And that includes breast and axilla. There is no way you can put somebody on neoadjuvant endocrine treatment unassuming that in 6 or 9 months you'll be able to find the lump whatsoever happen. You need to mark it, and if you don't have the facility to mark it, you can use it for less than 3 months, but not before that, and the lump should be having calcification or obviously palpable, otherwise you'll be in trouble. So the question, does the neoadjuvant endocrine treatment work? Yes, it does. It offers a reasonable and comparable outcome to chemotherapy with better tolerance and less side effects than neoadjuvant chemotherapy. The caveat is we are not using it interchangeably with chemotherapy. I mean, for ER positive, HER2 negative, you'll get a reasonable and comparable outcome whether you use chemotherapy or neoadjuvant endocrine treatment. You cannot use it interchangeably with other indication for chemotherapy. So these figures are really helpful. Between 30% and 75%, they will get clinically meaningful response. What does that mean? Clinically meaningful response, that means you can change the operation from mastectomy to lumpectomy, or from a mastectomy to some sort of oncoplastic treatment like perforator flaps or therapeutic mammoplasty. Clinically meaningful, because if I get a lady with 5 centimeter lump, a bra, and I stick her on a neoadjuvant endocrine treatment, and I see her after 6 months, and it is only 4 centimeter. It is smaller, but it is not clinically meaningful, and I still end up doing mastectomy. But 30 to 75% will get a clinically meaningful response. And on average, 60% will end up avoiding mastectomy. And that's not a small percentage, more than half. And 1/3 on average, they can avoid axillary clearance, although it is not a solid practice to use it solely to avoid axillary clearance. And you need to be careful when you consent the patient about neoadjuvant endocrine treatment. 10 to 30% no response at all. So you need to be realistic, not to promise the patient that it is going to work 100%. There is up to 30% chance that you will end up at the same point you started the treatment. And between 1 to 14%, you get a complete response and the cancer disappears completely in breast and axilla. If you compare this complete pathological response to chemotherapy, it is way less, because in HER2 positive cancer with dual anti-HER2 chemotherapy associated, you can end up having up to 76% complete pathological response, and you can get like mid-60s% in triple negative breast cancer with chemotherapy. So the complete pathological response is not as high as chemotherapy, but this is not the aim of neoadjuvant endocrine treatment. The aim of neoadjuvant endocrine treatment is to avoid mastectomy and to bridge social and medical issues. And the last one, although it is just 1.4%, it is very serious, legally binding, and you can end up with litigations and going to court or to the regulatory body if you don't document clearly that there is a chance, even 1 in 100, the cancer might progress during taking aromatase inhibitor. So I believe this is the most important slide, giving you idea about the percentage and also the framework when you discuss neoadjuvant endocrine treatment. If you can see with the green font at the bottom, there is ASCO Z1031. A clinical response is up to 69, 50% avoiding mastectomy, and the recurrence rate 5 years after that is just 1.5%, which is comparable to any breast-conserving surgery, regardless of whether you use neoadjuvant endocrine treatment or not. So we have the profile, we have the indication, we agreed to do it, and the patient will ask you for how long, and what is the dose, and what is the frequency. So for anastrozole, this is a standard 1 milligram a day, a tablet a day, letrozole 2.5, exemestane 25, and tamoxifen 20, and they are all only once daily. With aromatase inhibitor, we usually advise to consider vitamin D and calcium supplement to counteract the bone symptoms. With tamoxifen, you don't need that. And also, to be realistic, extremely unlikely to get any meaningful response less than 4 months. If somebody is going away for any reason and they want just to facilitate that, this is fine, but I don't expect any meaningful response less than 4 months. And if the plan to get any response before 4 months, the answer is no. And there is no evidence to suggest it is safe beyond 12 months. So your aim will be anything between 4 to 12 months. And on average, we say 9 months. Local policies and individual patient varies, but aim generally for 9 months to be safer, not crossing the bridge of 12 months, and also to be realistic, to get a meaningful clinical response beyond 4-month period. Do we send them with a tablet a day home and see them in 9 months? The answer is no. We need to monitor the response as soon as we expect a response, around 3 to 4 months. However, most importantly, you need to monitor the compliance and the tolerance and how they are coping with the side effects. And you need to see them or to give them a phone call as early as 4 to 6 weeks to make sure that they are compliant with the tablet and there are no severe side effects. And to see them clinically, plus or minus imaging beyond 3 months period. As we said, we don't expect any significant response below 4 months. Another point is to see them again, clinical assessment at imaging at 9 months, and a final clinical assessment around 8 to 9 months to plan the final surgery and to assess whether you need to extend or to start planning surgery straight away. However, regardless of the schedule of this follow-up, the patient should have clear instructions to look for progression and to report back directly to the surgeon, to the breast care nurse, or to the oncologist if there is evidence of progression, and they get clinical assessment and imaging as and when needed, regardless of the schedule. So, how we assess the response and what dictates the response first. We expect high-grade tumors to less likely respond. Patients with high Ki-67 also tend not to respond. And the menopausal status will affect as well. So more effective in postmenopausal in comparison to premenopausal, letrozole over tamoxifen, and generally, personally, I don't have evidence, but my personal preference is always letrozole as first start, unless the patient has rheumatoid arthritis or arthritis of any kind, or severe postmenopausal symptoms. And we usually expect to get better response in the breast than axilla, and a better response with ductal than lobula. All these will help you to reassure and to discuss these expectations with the patient so they will be realistic. So if you have a premenopausal patient on a tamoxifen with breast and axilla and high Ki-67 and high-grade tumor, I wouldn't be so optimistic, and I wouldn't give her very much hope that we can avoid mastectomy. But at least we give it a go and then assess. So, as I said earlier, to bridge social and medical issues and to avoid mastectomy, there are other situations we can use neoadjuvant endocrine treatment. One of them is 2 weeks short preoperative letrozole course to assess for the response of Ki-67. Even if we believe the patient is suitable to go straight away for breast conserving surgery, it is safe to try it, test the Ki-67, give them a short course of letrozole, measure the Ki-67 before surgery, and then if it is halved by 50%, that's a good sign. Or if it is low from the beginning and it stays low, that's another good sign. And there is another trials, like Biotic A trial with abemaciclib, and it is out of the scope of this topic. So I promised you to speak about interchanging use of chemotherapy and neoadjuvant endocrine treatment. This is a practice you can use to bridge the patient with neoadjuvant endocrine treatment before starting them in chemotherapy. That will shorten the period of chemotherapy. You'll get both benefits of chemotherapy and neoadjuvant endocrine treatment, and also with less cost in terms of side effects. It is not a standard, but it is not unheard of. So how the breast cancer responds? The most important thing, we need the whole footprint of the breast cancer to reduce. Otherwise, it is meaningless. If I have the maximum diameter as 5 centimeters and I end up with 49 millimeter, that's rubbish. That's why we need the whole breast footprint reduced to facilitate less surgery and to avoid mastectomy. However, it can be reduced density, or if it is a locally advanced, it can simply become operable of the skin or the muscle if it is a T4. Or in some cases, as we said earlier, up to 14%, you can get complete radiological response with the cancer disappearing altogether. Happy days. So the pattern of response is usually concentric reduction in size. It collapses from the edges onwards. You can get complete pathological response, and there is a specific histopathological data set called neoadjuvant response index. I will leave that to the clever pathologist, not for a unicellular surgeon. So these are imaging to see reduction in size. As you can see in the top, A to C, and then B to D. So unfortunately, I can't use my own patients here because of the confidentiality things, and this from the internet. And you can see clearly a good response on all these imaging. And you can see as good as this one. Very dense. You put a clip, start treatment, 9 months down the line, you can see only your calc and clip. Happy days. You end up avoiding big surgery, just wide local excision with minimal distortion. Last but not least, we all pray to our beloved Sudan. Thank you.
Thank you, Mr. Hussein. Very interesting topic and very thorough presented. Thank you so much. If there's any questions, any point we need to discuss, we can hear from the panel and the participants.
Assalamu alaikum, everyone.
Wa alaikum assalam wa rahmatullah.
Sorry, joined late in the middle actually in your presentation, Hussein. Well done, number one. As Tamadur said, it's thorough, practical, and just straight to the points of clinical practice. And just 2 comments, because as I said, I wasn't in the presentation from beginning. So because you said high-grade tumor and high Ki67 is not an indication for neoadjuvant endocrine. It's right, because this is obviously is indication for neoadjuvant chemo. So this is why I think the explanation is because it is straight away if there is a high-grade tumor or high Ki67, which high proliferation rate, this is a straight indication to neoadjuvant chemo, not endocrine. And yeah.
Let me answer this. For the Ki67, as you know, there is a threshold. So if you say more than 30, you indicate chemotherapy.
Chemo, yeah.
Between 20 and 30, you discuss either way.
And, yeah.
And under 10, you usually don't recommend chemotherapy.
Yeah.
So if there is a clear indication for chemotherapy, I said clearly in the beginning, neoadjuvant endocrine treatment is not an alternative to chemotherapy.
Absolutely. Sorry.
There is no interchanging. But to be careful, even if it is not high to the cutoff, you go for chemotherapy. If it is like 15, for example, this is not clear indication for chemotherapy, but you expect less response in comparison to a patient with Ki67, only 5.
Yeah.
You need to put this in mind. And the same thing, if you have grade 3 cancer, by default, just grade 3 is not an indication for chemotherapy. You have to have another indications.
Another indication, age, a lot of different.
Yeah, if the patient qualifies for chemotherapy, there is no place for neoadjuvant endocrine treatment. However, if it is only grade 3, postmenopausal, 1 centimeter or 2 centimeter, no other indication whatsoever, I can still use neoadjuvant endocrine treatment, but I expect less response in comparison to grade 1 or 2.
Yeah. And the other point is about why letrozole. You said you go straight to letrozole. I use the same concept if I'm thinking that I need like quick response, because from the research, it is well known that letrozole, it is the strongest one of non-steroidal aromatase inhibitors. So it is more stronger than anastrozole. This is the reason why if I got like, for example, big tumor, high risk, just like the tablets to work very well, I use letrozole. But if there is an old lady, a small cancer, and So we use anastrozole. See, so the reason for using letrozole because it is the strongest non-steroidal aromatase inhibitor, is stronger than anastrozole.
Mona, you missed my first slide.
Sorry.
It is clearly evident that letrozole is the most potent out of the four as estrogen suppressor, but there is no clinical evidence it is superior to them in the clinical practice. Assuming that you know for sure it is most stronger one, there is nothing to stop you from using it unless proven otherwise. But there is no head-to-head neoadjuvant endocrine treatment comparing letrozole, anastrozole, and tamoxifen with solid evidence to say clearly that letrozole is superior and you get this percentage of response in comparison to anastrozole.
Yeah, so this is what I said, more potent than anastrozole. And we can compare aromatase tamoxifen because we all know we use tamoxifen in adjuvant setting in premenopausal ladies. So it is completely different scenario because we use tamoxifen in premenopausal ladies with other comes to blocking of the ovaries. So let us just focus in neoadjuvant setting mainly because aromatase inhibitor in both menopausal ladies. So this is the comparison come from either between letrozole and anastrozole versus exemestane, which is steroidal aromatase inhibitors.
My question directly to you, do you have any evidence or trials comparing head-to-head neoadjuvant settings, anastrozole, exemestane, and letrozole?
Well, I think that I don't know because there is a lot of treatment general, but no, I don't know.
Muna, we think the network is a bit interrupted. We cannot hear you well.
Okay.
If you can just check your network.
Can you hear me now better?
Yeah, this sounds better. Thank you.
What I said, I think it's difficult to compare tamoxifen with aromatase inhibitor because we use tamoxifen mainly in premenopausal ladies.
Alone, do you have evidence that in clinical trial that letrozole leads to better outcome clinically in comparison to anastrozole?
Not on the top of my head, but it is from trial there is I can find out it is more potent than anastrozole, letrozole.
Potent is not our discussion. It is proven to be the most potent estrogen suppressor.
Yeah, so this is what I.
But it is a different thing, Mona, to know it is in vitro, in the lab, it is the most strong, or to translate this to clinical practice with a meaningful difference in comparison to exemestane and anastrozole. This is my question. I personally believe it is the most strong one, and I personally use it whenever I need good response, but I don't have scientific evidence to support this. Hassan, you are.
All right, Hussein and Muna. Yeah, this is very nice discussion. We can listen to Dr. Ghassan as well. Mr. Ghassan, if you want to share your thoughts as well.
Assalamu alaikum. Thank you, Mr. Hussein. This was a very nice and thorough presentation.
السلام عليكم.
وعليكم
معلش
السلام ورحمة
والله
الله
أنا
وبركاته.
عندي ارتباط الساعة 2 حاسة الساعة 2 إلا 10 إذا ما
Alright.
قدرت أقدم حاسة معلش ممكن أسجل في وقت تاني.
لا ما في مشكلة، أنا خليك تقدمي طوالي ونأجل الدسكشن ده لبعد التقديم بتاعك إذا ما عندكم مانع. دكتور غسان، دكتور حسين، دكتور منى.
For a while and I will join to complete the discussion with me.
تمام. You might join after Ms. Adi or any time that you think suitable for you. Thank you.
I'm sorry والله لكن لأنه غيروا المواعيد دي كم مرة وأنا عملت السكيدول بتاعي على التغيير ده.
ما في مشكلة. That's all right, Ms. Aida. شكرا for sharing your commitments. All right, so all right, our next presenter would be Miss Aida Mustafa. She's a senior and renowned oncoplastic breast surgeon practicing in Sudan. and she will be sharing with us the topic of implementing oncoplastic surgery in resource-limited setting, with particular focus on the situation in Sudan. So thank you, Ms. Aida.
Thank you. Good afternoon. Thank you for giving the opportunity to produce my talking. I'm sorry again because I have a commitment. I have to go. Oncoplastic surgery in low and middle-income countries is a mandatory now. I think it's mandatory to have oncoplastic surgery and there is a lot of countries which is started to develop oncoplastic surgery in a setting of low and income countries. So why do we consider oncoplastic surgery in low and middle income countries is cost-effective alternative to conventional breast conserving surgery, in spite of the fact that it's time-consuming, firstly, and it may be most costly, but it's important that it reduces the redoing surgeries and it reduces the safety margins could be saved. So our objective is to define oncoplastic surgery, list low and middle income countries where we are.
السلايد ما ماشي.
نعم.
السلايد ما ماشي.
اوكي. ما عارفه الستوب شيرنج ليه ستوب شيرنج من انا هنا I'm sharing it.
اقفليها وافتحها تاني. ايوه
كده ظاهره لكم.
ايوه
اوكي
سلايد شو. اوكي
اوكي
ايوه
كده.
كده واضحه. ايوه تمام.
اوكي كويس. Our objectives is to define oncoplastic surgery, list low and middle income countries where we are, what has been done in countries like ours, and what are the challenges we are face and how can we go over it. The term oncoplastic surgery is credited to Professor Werner Udrich from Germany, from Düsseldorf. He made a pioneering contribution in refining and popularization of the technique and training in oncoplastic surgery. He founded in 1990 a dedicated interdisciplinary press center at Düsseldorf in Germany, offering training in art of oncoplastic surgery. Since then, there have been many surgeons in Europe, UK, USA, who developed the skill of oncoplastic and have taken this forward to different levels. Oncoplastic surgery can be defined as a tumor specific with immediate breast reconstruction, applies aesthetically derived breast reduction techniques to the field of breast, and allows for a higher volume excision with no aesthetic compromise. The procedures involved are more complex and time-consuming than those in breast conserving surgery. The aim of oncoplastic surgery is to ensure better cosmetic outcome and eliminate the need of correction of defects resulting from breast conserving surgery. The average specimen for breast conserving therapy weight, it varies from 20 to 40 grams compared to 200 grams for oncoplastic surgery, though the specimen can weigh up to 1,000 grams or more. So how do we classify oncoplastic surgery? Level 1, less than 20% breast tissue removed. So this is placement of incisions or local tissue rearrangement or crescent mastopexy or donut Pinelli mammoplasty or inframammary crescent. So this is shows the donut Pinelli mammoplasty. And this shows crescent mammoplasty. And the second level is 20 to 50% of breast tissue removed. And this is include circumvertical with superior or supromedial pedicle, central mount, inferior wise incision, or supromedial pedicle wise or central cancerous with free nipple graft. I will show some examples. This is circumvertical with superior or supromedial pedicle. And this is central mount or inferior wise. And this is supromedial pedicle wise. Then volume replacement if we need to remove more than 50% of breast tissue. And this can need implant reconstruction, local or regional flaps, such like latissimus dorsi flap or tram or other flaps, or perforators or lipofilling. So what's the benefits of oncoplastic surgery in low middle income countries? It improves cosmetic outcomes, combining tubal removal with plastic surgery, maintains aesthetic appearances, which can significantly improve a patient's quality of life. Reduce re-excision rates by allowing for wider removal of tumor by oncoplastic techniques, significantly decreases rate of positive surgical margins. A lower need for re-operation, it lowers the need for re-operation and can save limited resources and decreases the burden on the healthcare system. Also, it increased the preservation of the surgery and for those who otherwise might need the mastectomy, so we can save the breast. This offers major psychosocial benefit as many women regress undergoing a mastectomy. It's a cost-effective, while the initial procedure can be complex. The reduced necessity of second surgeries and readmissions make oncoplastic surgery most cost-effective in the long run. What are the challenges in the low-income countries? Training and expertise. A primary barrier is the scarcity of surgeons adequately trained in oncoplastic surgery. Unlike in many developed countries, the collaboration between breast and leg surgeons is not very easy and is not always harmonized. Some innovative solutions include creating a one surgeon your role model with collaboration with the international centers. Other challenge is the late-stage diagnosis. A high proportion of patients in low-middle-income countries are diagnosed with locally advanced breast cancer. This late-stage presentation often makes mastectomy the more common surgical procedure. Patient factors. Many women face barriers like low socioeconomic status, lack of awareness, and psychosocial factors which can affect their understanding and acceptance of the oncoplastic options. Patient and clinician education is necessary. How can we promote oncoplastic surgery in low-middle income countries? To overcome these barriers, collective efforts are needed from the global media community, with some initiatives showing promise. Focused training programs that train surgeons in both oncologic and aesthetic breast surgery have proven effective in increasing access to reconstruction, as in India and Brazil. Research collaboration, post-operative, prospective, multi-center trials and registries are needed and need evidence on the utility and challenges of oncoplastic techniques within a specific limited context. Breast surgeons in countries like India and Brazil have adapted oncoplastic techniques to be more suitable and affordable for their patient population. Patient advocacy, increased awareness and advocacy can help address to strengthen the misconceptions that that may prevent from pursuing breast conservative options. Lack of standardized practices. There is need to standardize surgical indication and techniques and quality metrics to improve outcomes and facilitate data collection. Radiotherapy access is the limited availability of radiotherapy facilities is a strong obstacle that increases the rate of mastectomy and limits the feasibility of breast conserving oncoplastic surgeries. So we come to the second part. How do we classify low and middle income countries? Low and middle income countries are nations classified in the World Bank desk having a gross national income per capita below the high income countries threshold. They include low income, lower middle income, and upper middle income economies, generally clusterized by developing economies. Key characteristics and examples represent drives group across Africa, Asia, Latin America, and parts of Europe, often defined by lower per capita income compared to developed nations. So by April, these are the low middle income in countries in Africa. And as you see, even Egypt, even Ethiopia, Libya, and Tunisia, Uganda, Sudan for sure, in Asia, Afghanistan, a lot of countries, but I concentrated on the countries that we have taken as examples, India also. In Latin America, Argentina, Bolivia, Brazil, Colombia, Costa Rica, Cuba. And even in Europe, there is some countries which are considered as low income, like Albania, Armenia, Azerbaijan, and Georgia, Bosnia, and Herzegovina, Russia for some time, but it's changed. I will show you how does it change. So, This stopped again. Sorry. For 2026, low middle income countries include nations with general national in capita. In the low middle income countries, they are estimated the gross national income 1 to 1.3 per capita income of a person. In the lower middle, the income is 1.1 to 4.5 approximately, and in the upper middle income, the gross national income per capita, it's 5 to 13 dollars. These nations, spanning Africa, Asia, and parts of Latin America, represents the global population, including countries. So here we can see how the map is changing. So sometimes we were in the low middle income, but now we came back to low income countries by 2026. So now we are in the low middle income countries. So the context that the World Bank Group is committed to helping developing countries achieve health coverage through a stronger, more resilient health system and produce quality, affordable health services to everyone, especially the most vulnerable. By prioritizing health, countries build the foundation for the human capital for creation and shared prosperity and improve social well-being. The World Bank ambitious plan to support countries to deliver quality, affordable services to 1.5 billion people by 2030 aims to address the significant inequities in about half of the global population without essential health services and 2 billion people in severe financial hardship due to healthcare costs. So, shrinking facial space, emerging disease challenges and threats and climate changes, along with non-communicable diseases and aging population, significantly impact quality, affordable health services for all. Our $27 million global health portfolio include 160 projects that are helping countries on health outcomes by implementing substantial financial reforms, redesigning, primarily creating predictable regulatory environments for private sector engagement and general health workforce throughout digital innovation and mid-level provider training. The Global Financing Facility for Women, Children, and Adolescents and the stockholder partnership hosted at the World Bank has been supporting countries sorry, it seems I have touched something. that has been supporting highest maternal and child mortality burden and financial needs. Since this organization founded in 2015, partner countries have made significant progress to improve maternity and child health. This is about our presence as a low and middle income countries and about the commitment of the World Bank towards these countries. So we should have addressed this. And the World Bank has started this work before the war, and they were providing mammographies and providing aids, and all these things has been stopped by the war. So we are studying the Brazilian experience in spite of the fact that Brazil now is going from low income countries to upper income countries, but the Brazilian prosthetic surgery market is certainly a case that deserves being studied. The encounter between a tropical climate and a Latin culture has favored its growth. A very receptive client base in an aesthetically oriented society. According to the most recent study on aesthetic procedures from the International Aesthetic Plastic Surgery Brazilian plastic surgeon, performed almost 7 surgeries per 1,000 persons in 2016. This is surprisingly high, especially if compared with 4.6 procedures per 1,000 performed by the American College in the same period. Also the Indian experience, India, wherein mastectomy still remains the mainstay of cancer treatment. Many centers now adopting breast conservation surgery is accepted, but they are moving towards oncoplastic training. Now is incorporated as an important component training in advanced certified courses in surgical oncology, recognized educational bodies. There is a study about oncoplastic breast conserving surgery in African women. And this systemic review revealed that the outcome of oncoplastic surgery in African women with that underdeveloped countries, literature search about 266 articles, but only 26 of these were included in the study. Majority of the studies were from Egypt and South Africa. The studies collectively evaluated 1,896 patients with a mean age of 48 per year. Mean follow-up period was 69.9, about 37 months. The most common histopathology was T2, 71.4%, invasive delta carcinoma. And this included patients who are receiving neoadjuvant chemotherapy. This systemic review revealed that outcome of oncoplastic surgery in African women with that, hook wire localization was the most common technique used for non-palpable breast tumors, which compared 85.3% of patients. Of the study reporting oncoplastic technique, the latissimus dorsiflap, a volume replacement technique, was the most reported. Most patients were satisfied with their cosmetic outcome. Seroma was the most common postoperative complication. Among studies that reported oncologic outcome data, the crude overall survival-free survivor were 93% to 89% respectively. So this is in the countries around us. So what is in Sudan? What we can do, and what our challenges, and then we will come to what we can do. Absence of printed guidelines in most hospital and medical centers, and even in the private centers. Cancer care depends on each particular treating physician. Cancer care depends on available resources, and it depends on ability to access care, and it depends on patients' ability to pay in many occasions. Care depends on special referrals, seeking and getting to particular well-known physicians and hospitals. Morbidity and mortality exercises are rarely practiced in hospitals. Monitoring of outcome is limited to a few major academic centers who perform clinical research. Medical liability, minimal physicians and hospitals may easily get away with errors. Few systems to protect patients, no fair compensation, some rule disproportional penalties, fatalistic attitude of families. Patient education is variable but limited in most places. Printed and clear patient information is present in a few places only. So what is opportunities? Adopting national amended guidelines, implementation of guidelines in general hospital and in private hospital as well. Writing and monitoring clinical pathway for hospital-based physicians, and implementation of guidelines for individual clinic-based physician. Writing and monitoring of pathways for private practices, monitoring of practice guidelines and applied. We need to know who makes sure they are applied and how to make sure they are applied, and need for monitoring. Tumor board conferences help implementation. Our objectives is develop guidelines, implementation strategies, and monitoring. Establish national limited number of cancer centers, institutes of non-strong training programs to offer training fellowship, and provide candidates accreditation of comprehensive cancer centers. So it is high time to establish the Society of Breast Surgeons and to start the fellowship of breast surgery at the Sudan Medical Specialization. And thank you. Also, adoption and dissemination of amended guidelines, how to apply them. Active use of guidelines as an educational tools to change the practice of breast surgery, and also enhancement of research and collaboration between multi-sectors or multi-centers. Fundraising through healthcare national and international organization, World Bank, and involvement of local stakeholders. And thank you.
Thank you, Ms. Aida. Thank you for this great presentation. And it's quite related to our practice in Sudan, and really quite important thing to discuss. So thank you for your presentation.
Okay, thank you. And if there is question, because I'm sorry, I have a commitment. Yes, if there is any
if
question.
there's any quick questions, any points that any discussion, so please go ahead.
ممكن بس البوينت يا دكتورة تماضر. Thank you, Dr. Aida. Very interesting presentation. Thank you very much.
Okay.
Thank you, Aida. Very important topic. I think we all have to think about creating a center where we can have a specialized breast service done, like the breast care center in Sudan. We have private one, but we should have a governmental one.
The
And I think the
national one,
most,
yes.
yeah, and I think the most important thing is the getting a trained staff who can do the oncoplastic service and try to train as many junior doctors to do this service and get this culture in is important. I don't think the oncoplastic surgery itself need a lot of facilities, but I think we have to invest in the personnels. This is the most important thing, and I think one of the priority of the Ministry of Health and the governors in Sudan is to make sure that we train good number of staff to continue this service. Again, very important topic. Thank you very much, Aida.
Thank you.
Thank you, Mr. Omar.
Thank you.
Thank you, Aida. Really very important topic. And I think that all of the gathering we do, guided by Rabab, is for this concept to have like a proper system, a proper way to train our people and to treat our patient in Sudan in a better way rather than what is happening now. So it has to be like a collaborative effort between all of us as multidisciplinary. And as Mr. Omar said, yeah, training is an issue and facilities as well. We can't control facilities, but we can control training from our side. And we are happy to train because we got a lot of oncoplastic surgeon abroad. So we are so happy to start the process of training, starting from these webinars. This is the good start. And then hopefully after this war settle, yes, we'll carry on. We'll carry on. And
Exactly. Yeah.
Yeah.
Thank you, Mona. Thank you, Ms. Aida. And
I think the most important thing is to have the place and the proper channel for doing the training. So we should have bodies, or we should have institutes like the international institutes for training the junior colleagues. And as we have a lot of oncoplastic surgeons, we have a lot of cadre outside Sudan. We can recruit them even for short courses. So in India, there is courses of 6 months to 1 year for oncoplastic surgery for basically surgeons. So we can do short courses. But we have to have the place. We have to have the institute to have this. To organize this training. It should be organized, it should be certified, it should be accredited. And also, Dr. Amuna, we can make use of the opportunities from the World Bank, from the other institutes. Even we can raise funds from the national and international organization to do this. But we have to have persons who are committed to do this.
When we came, Aida, when we came to the workshop, February 2023, 2 months before the war, and I think Mr. Omar and Ghassan can remember that. And out of this workshop, because we have seen how the trainees are eager to have the training. And out of this, I think we have made like a group, and there's an idea of performing like a fellowship during Sudan Medical Specialization Board. So we started this process. I think we included you and a lot of breast surgeons on that group. And so if this is a good start, because through this, because it's going to be accreditation, it's going to come from the Sudan Medical Specialization Board. And then, yes, we wanted to finalize the best way to do that, but out of control the war.
Exactly,
We'll go back to where we started from.
So this is quite a valid point, and this is related to what Dr. Rabab mentioned a bit earlier, that we can start with a study that has been suggested by yourself, Ms. Aida, in the last symposium in October, that we need to do like what we call like a survey study to assess situations at the moment and see what exactly needed. And then from that point, we can start. So Dr. Rabab was asking whether that study has been established or is still under planning.
The questionnaire is ready now, but I found it heterogeneous because I designed the questionnaire to know the infrastructure, and we need to know the infrastructure in radiology. We need to know the infrastructure in pathology, in oncology. So I may need some meeting with the group to discuss, to do it separately. One questionnaire for the radiology department, one for the pathology, and one for the surgery, or to do it for the whole group. It's a very heterogeneous, and
All
we
right.
need
So
to know
that a good
what is
starting
going
point, Ms.
on.
Aida.
Yeah.
Yeah. So we can get the help as well from other expertise, like for example, the
Yeah.
epidemiology and public health team.
Definitely.
They can really help with designing this questionnaire to be more targeted to that population,
Yeah.
and then we can apply it and just collect
Yeah.
the data. So we can
Yeah.
arrange that meeting, put this plan into action, and
Yeah.
have like a time plan for
Yeah.
that. When to
In
start, when
fact,
to have that meeting, and what the personnel that might be helpful.
in
And
fact,
also,
I
we need to
have
discuss whether this study will be ready to be discussed in October of this year, or we need to postpone it and just present it whenever it's ready and have another topic for October of this year. What do you think?
Yeah, in fact, I have the questionnaire ready, but at the end I found who is going to fill it. I need to know at the practice level who is
Yeah.
doing the radiography. For example, in the group, I saw some mammography who was done by a technician, by an X-ray, by a normal X-ray. And so who is doing the radiology? Who is doing the histopathology? Who is doing the surgery? And what the
Yeah.
infrastructure now?
That would be a bit difficult to answer at this situation, isn't it? Because
And
we
it's
do
changing the
work
whole
in
time.
exceptional situation. It's not the ideal situation at the moment. It's a weird situation, and things
Yeah.
are not really done in the way that usually been done. So
Yeah.
we might need to modify that
And
as
it
well.
is changing all the time. Every month it's different.
Yeah. Okay.
يعني there's
So
a
that's
lot
another
of
point we
change
need to
taking
consider as
place.
well.
Sorry, so when it will be the starting point for this study, and is it going to be discussed on next October or not? Because just we want to readjust our schedule for this year.
I think we have about 6 months to October. So I think if we can sit and design the questionnaire and distribute it, we can have the results by October.
Okay, good. So yeah, we can start
I
on this
have
plan.
suggestion, Dr. Aida. Dr. Aida,
Yes.
Yeah.
I have suggestion. If you don't mind, يعني if you agree with me. طيب احنا نمشي البلان. طيب عندنا الآن عندنا one day symposium about overlooked breast cancer في كل الديسيبلين or missed breast cancer. طيب كنا عايزين نعمله في ماي وفي ناس قالوا ما جاهزين يأجلوه شوية، ففي كان عندنا الادفانس بريست كانسر في جولاي by the end of July. فأنا قبل ما نبدأ اتناقشت مع تماضر بحيث إنه يعني أنا خدت في بالي السجشن بتاعك أنت لأكتوبر، ويعني عشان نعمل adjustment للتو توبكس ديل، فبقترح إنه نحن نمشي حق ماي في جولاي وحق جولاي في أكتوبر، ونشتغل في الاستادي. متى ما الاستادي بقى ريدي at any time نعمل له سيمبوزيوم يكون related للموضوع ده يعني لحاله كده، عشان يعني لو بيكون في ريسك اذا ما لحقنا خلصنا في اكتوبر والبلان بتاعتنا هتتلخبط، فاحنا ما مشكله خلص قبل اكتوبر، احنا نعمل له وان داي سيمبوزيوم ونناقشه. خلص بعد اكتوبر نعمل له وان داي سيمبوزيوم ونناقشه.
ما في مشكله.
تمام. This
كده مش
sounds very,
افضل؟
very flexible plan, دكتورة باب. At least this sounds as a flexible plan. يعني حتدينا
Yes.
flexibility كويسة. وفي نفس الوقت لأنها population based study احنا we cannot predict how long
Yeah.
it will take.
No.
وعايزين
Yes,
نعملها
it's true.
بطريقة proper. فالأحسن نقطة
عايزينها
مع
بروبر،
things.
عايزينها بروبر عشان ما
أيوة،
نضغط
فممكن
روحنا،
نخليها
وإذا حصلت أي إشكاليات، فعلى كده نخلي الميس بريس كانسر by the end of July، وأكتوبر يكون عن advanced breast cancer not locally advanced metastatic and local. طيب، وأنا أخلي الموضوع بتاع البروجكت ده flexible، والناس
Whenever it's ready.
تحاول إنه to start from now. متى ما جهز الناس تعمل له سيمبوزيوم وتقدمه.
طيب, can we set like a time frame when we could meet to finalize the questionnaire? Identity, you are ready. So let's include the other branches.
أي ما في مشكلة، عايدة تديني خبر وأنا بنزل إعلان في الجروب للميتينج عادي. يعني كحاجة رسمية إنه هيكون في ميتينج بخصوص الحاجة دي، وإذا أي حد عنده تحفظ على المواعيد ممكن نعمل adjustment بحيث إنه أكبر عدد من الأعضاء يكون available.
Perfect.
طيب أنا من هنا لغاية 24 أبريل حكون فاضية. فإذا باقي disciplines دكتورة نادية أنت كيف معاكي؟
طوالي.
يعني أوكي.
يوم كم؟
لغاية 24 أبريل.
من هنا لحد 24 أبريل تقصدي؟
يس، يعني 20 يوم دي أنا حسب يعني أبقى available. بعد ذاك حكون شوية مشغولة يعني.
أوكي طوالي. anytime you say.
شوفوا
طيب نحن
ممكن
عندنا
نحدد أي سبت أو أي أحد الناس بيكونوا شوية فيه.
أيوة، لأنه نحن عندنا دكتورة آمنة باثولوجي حتقدم عن الريسيرش ميثودولوجي جمعتين، وعندنا لكن حتكون جمعة يعني، فما مشكلة ممكن نعمل في أي سبت فيهم.
تمام.
واسمه منه هو MDT. فنحاول نشوف الآن، أنا بعمل استفتاء في الجروبات، نشوف أنسب سبت للناس تجتمع فيه، وإن شاء الله بدي خبر قبل 24 أبريل.
أوكي
تمام.
طيب إن شاء الله.
إن شاء الله.
أوكي. Any further discussion?
طيب تمام، إذا ما في more discussions we can proceed with the presentations. Thank you Ms. Aida. Thank you so much. Appreciate it.
Okay, thank you so much. I'm sorry I have a commitment. غيرته كم مرة يعني عشان السكيدول اتغير كم مرة I have to go.
تمام، بنعتذر على التأخير كمان صراحة، ما كنا عندنا فكرة إنه عندي commitment.
كتر خيرك
فكنا
كتير،
just
شكرا
following
لك
الليستة زي ما هي.
وبنعتذر منك.
ما في مشكلة. أنا بعتذر لباقي البريزنترز، وإن شاء الله بشوف التسجيلات إن شاء الله.
تمام بإذن الله. شكرا Ms. Aida.
السلام
Thank you so
عليكم.
much.
الله يبارك. الله يسلمك.
All right, so our next speaker will be Ms. Muna Suleiman. She's a senior oncoplastic breast surgeon practicing in the UK. She will be discussing with us the topic of mammoplasty in relation to the theme of early breast cancer. So thank you, Ms. Suleiman. If you can start and share your slides, please.
Okay, just sharing now. Can you see my screen?
Yes, we can see it. If you can just be on a play.
Oops.
That would be the fourth icon, Mona, the one after it.
I'm just, because it's difficult, I'm pressing now the fourth icon and it is multiple.
Yeah, I think you just press the third one. You just need to press the fourth one.
Yeah.
Yes. Thank you.
Right. Thank you so much. Thank you, Tomadur, for introduction. Thank you, everyone. Thank you, Rabab, for your effort, as always. And doing this topic, which is oncoplastic breast surgery volume displacement. And again, we need to pray for Sudan for peace to happen, inshallah, for our people. Can you see my screen moving?
Yes, we can, Mona. Carry on. Thank you.
Right. I think in presentation of Ida, she spoken a bit about what is the concept of oncoplastic breast surgery. Oncoplastic breast surgery simply is integration of oncological removal of the cancer combined with plastic surgery. So this is the concept of it simply. And as she said, we need to have like a proper training because there was a lot of like discussion initially before the introduction of the concept of the oncoplastic breast surgeon. Who will do that? Is it the breast surgeon to do oncological treatment and then plastic to do the plastic work, or no? We have to combine, as a surgeon, to combine both terms by doing a specific training. And now there is a lot of opportunity to have, as we discussed in Ida presentation, to have a training to do oncoplastic work. So breast surgeon can do this training, specific training. There are a lot of channels to do that, to become oncoplastic breast surgeon. And I think Ida has covered all that. I'm not going to repeat that. So the whole idea of that, we discussed it. And because of the breast cancer ladies, they live longer nowadays. So they have to have a better quality of life and good self-esteem after cancer treatment. And because of, if we do breast conserving surgery without combining this with oncoplastic, usually we got a poor cosmetic results. So the whole idea of oncoplastic breast surgery to improve the long-term outcome of breast conserving surgery, especially we know there is a combination of radiotherapy that might affect the breast cosmesis. And the other thing about oncoplastic, it facilitates removing, as Ida said, more volume of breast tissue than the traditional volume. The most important paper in oncoplastic breast surgery, it is Krishnaklov's paper that was published back in 2010. This is very important paper because the idea of this paper to develop like an atlas to guideline the way of how to do the oncoplastic surgery depending on each quadrant. And the most important thing, in my opinion, from this paper that Krishnakov has managed to classify the oncoplastic breast surgery into 2 levels. And as you can see from his paper, level 1, volume, usually when we do normal wide local excision, usually we take up to 10 maximum, 15 maximum % of breast volume, and then we should be able to reposition or to repair the breast tissue to have a good acceptable results. But when we move to the oncoplastic breast surgery in level 1, we can remove up to 20% of breast volume. And in level 2, we can take up to more than 50%. Actually, it used to be 20 to 50, but nowadays we are speaking about what is called extreme oncoplastic. And extreme oncoplastic, we can speak about taking more than 50% of the breast volume. So, and in level 1, there is not actual mammoplasty, but in level 2, it is a mammoplasty. And the glandular characteristic, usually we use level 1 in dense breast tissue, and level 2, we can use it for dense or fatty breast tissue. So this is the indication of oncoplastic breast surgery in general, where we take, as I said, more than traditional volume, which is more than 15 to 20%, and where there is adverse tumor location. So if we take a tumor location from certain part of the breast, definitely we'll get less cosmetic results, which is superior medial, inferior, and sometimes the central breast. And we do oncoplastic breast surgery even if there is multifocal or multicentric disease. It used to be indication for mastectomy. Nowadays, we can do breast conservation with multifocal and multicentric disease with oncoplastic work. Macromastia, where the patient benefit from reduction because the macromastia is a struggle for the ladies, and also the radiotherapy affect definitely the large breast. So making it smaller definitely will help. And if the patient, they are not suitable for neoadjuvant treatment, this means we need to take large volume of the breast. So this is what we used to do in the past before the concept of oncoplastic breast surgery. This is the lower breast, 6 o'clock position. When we take the breast cancer in the 6 o'clock position, can you see my cursor?
Yes.
What happened usually?
Yes,
We got lots of volume, we got scarring, and this scarring pull down the nipple, and we got the typical what is called bird beak deformity. This is used to happen a lot before the concept of oncoplastic, which if you can see is not nice. Adverse tumor relocation when it is in the lower ball. If we don't do anything oncoplastic, this is the end results, which is horrible for the ladies because, as I said, they live longer now. And if the tumor in the upper central, the breast, this is what we get. Right. What is the techniques of oncoplastic? There is 2 techniques. What is called volume replacement. In volume replacement, it is when we take the volume of the breast, we replace it with some tissue from around, not from the breast itself. And in the volume replacement, the technique we use is perforator flap, chest wall perforator flap. Hassan will speak about that after me. And lipomodeling as well. Lipomodeling just take fat from somewhere else in the body and inject it where we have the volume deficiency. And the second technique is volume displacement. Volume displacement, when we take large volume of the breast and reposition the rest of the breast tissue to fill in the defect of we took for the excision of cancer. And this can be classified, as Krishna Kloff said, into 2 levels, level 1 and level 2. We spoke about that. And the example of level 1, where we don't need to have like big excision of the tumor, we don't need to have a big excision of the skin, we don't need to have a big excision of the parenchyma as well. The example as bat wing or round block. And in my opinion, maybe Ghassan can agree with me, because we use level 1 for medium breast volume or small breast volume with no ptosis or small ptosis. And so we can use level 1. But nowadays, for the same group of patients, we can use volume replacement. So in my opinion, level 1, we don't do a lot of level 1 nowadays because it is replaced by volume replacement, which is most commonly the chest wall perforator flap. In level 2, which I'm going to speak about, which is more complex procedure, where we need to remove large tumor, we need to remove more skin, and we reposition the breast tissue to make it look better cosmetically. So this is example of level 1, bat wing mastopexy, and the name came from the way of the scar and how it look. And it is typically can apply this where the tumor is close to the skin and around the nipple. So we can excise the tumor, we can excise a little bit of skin and replace this small area where we take the tumor with some tissue from under the breast, and then we close it, and we're gonna give a bit of good results and a bit of uplift. And this is the round block. Ideally of the round block, which is level 1 technique, we do the scarring or the incision around the nipple, and we de-epithelialize the area around the nipple. And here it is much more clear. So this is the way we mark it. We mark around the nipple, inside around the areola, and a little bit out of that areola, and then de-epithelialize all around the areola, and then we open up the skin and lift off the skin flap completely off the breast tissue, and then we excise the tumor. So this is much more. So when we lift up the whole flap and excise the tumor from here, then we just put the rest of the glandular tissue together and then close up the skin around the areola. And this is how it looks after we do the operation. Okay. Right. This is quickly about level 1. And as I said, because we don't do it a lot nowadays. We'll move to level 2. And as I said, in level 2, we need more volume of excision, more skin removal, and reduction of more breast tissue and mobilization of the breast tissue to fill in the cancer defect. So, and there is 3 concepts for level 2 or volume displacement, or what is called mammoplasty. So we need skin reduction, we need parenchyma reduction, and we need pedicle. Pedicle means this is the tissue from the breast where we leave the nipple to live on, that to give the nipple blood supply. And the commonest way or principle for skin reduction, we use either vertical. In peri-areolar, we talk about level 1, but in level 2, commonly we use either vertical. This is the way we remove the skin or reduce the skin, or Wise pattern. This is about skin reduction. About parenchyma reduction, usually we have to remove where this is the cancer. So instead of removing the normal breast tissue in reduction for cosmetic reason, usually we remove the tumor as parenchyma reduction. So for example, if it's a tumor here, here, and here, we leave the pedicle here for the nipple, and this is going to be our excision. So we need to remove the tumor as parenchyma reduction. So this is the oncological procedure. And the last principle, we have to create a pedicle for the nipple, because we reduce the skin, we reduce the parenchyma, and then we have to let the nipple live on some pedicle. The pedicle, the most commonest pedicle is either superior pedicle, that the blood supply comes from superior pedicle from the second intercostal artery. Superior-medial pedicle, the blood supply usually comes from the third intercostal artery, and inferior pedicle, the blood supply commonly comes from fifth and sixth intercostal arteries. Right, so this is upper ball tumor. So this is one of my colleagues. He done it, got an award in the theater, and I guess I borrowed this slide from him. This is Mr. Brown Tamador. So this is where, if the tumor is the upper ball, so this is going to be our excision. This is going to be the blue color bit. The tumor is red, the blue color. This is our parenchymal excision, and the pedicle is going to be superior. So, sorry, inferior. So it's opposite to excision. Or most of the time, the pedicle is opposite to the volume excision or of the tumor side. So this is how it looks, the inferior pedicle. So this is the tumor on the upper part. It is removed, and this is the inferior pedicle. So we just de-epithelialize the pedicle and leave the nipple areola complex, and then we just lift it, the nipple here on the area of the nipple, new nipple, which is going to be more uplifted. So because mammoplasty gives us more uplift and reduction. So if the tumor is elsewhere, for example, in upper inner quadrant, and because this is very tricky area, this is where's cosmetic outcome, as we remember from early presentation. So we need to fill in, because this is where you get the cleavage of the breast, and the ladies, they care a lot about the cleavage. So if we add the tumor in the upper inner quadrant here, we can do what is called extended inferior pedicle. So we'll do the inferior pedicle for the nipple, but we leave more breast tissue just to tuck it in here in the area of the tumor, so as to have a better volume replacement at the site of the tumor. So this is the example of the tumor in the upper inner quadrant, and this is the extended pedicle. So we leave all this tissue, and then when we reduce the skin, we get this tissue. We leave the nipple here in the new nipple position and get this tissue inside to fill in where the tumor is. So this is how it looks in the operation. So because this is the whole pedicle, and this is the more tissue above the pedicle, so as to be tucked in the upper inner quadrant. This is how the lady looked after a couple of years, quite natural, reduced, and a little more uplifted. Well, for the tumor in the lower ball, if you got the tumor in the lower inner breast where we used to have bird beak deformity. So what we, if the ladies, they are big and they need reduction, we do what is called either superior or superior-medial pedicle for the nipple, and then we take the reduction at the site of the tumor, which is the whole lower pole of the breast. This is how the superior-medial pedicle look, and this is the tumor was removed because you can see is reduction, the whole tumor, and as Ida said, we with oncoplastic, we avoid probably taking the ladies back for the excision of margin because we feel free to take big volume. So this is a tumor, remove the whole lower ball of the breast, and this is the superior medial pedicle. Just quick example and how the mammoplasty is life-changing to the ladies. This is one of my ladies. She got a tumor on her upper inner quadrant. As you can see, she's macromastia, which is indication for level 2 mammoplasty. This is how we mark, which is a wise pattern, the skin reduction way. And this is inferior pedicle, 2 weeks after the surgery. And this is like 1 year after the surgery. Breast settle and look nice, but this lady, she didn't want to have symmetry because usually the downside of mammoplasty or level 2, we have to do something for the other breast for symmetry. Another lady, macromastia, tumor upper central. This is inferior pedicle as well, 2 weeks after surgery, few months after surgery. And this is when she come for the contralateral symmetry. And this is few weeks after we have done the symmetry. So this is where it started from. This is where she ended up, which she was quite pleased because she got a reduction, good shape and size breast. Another lady in her 50s, and she got a tumor in the upper inner breast where we used to get a lot of cosmetic problems. Again, inferior pedicle. 2 weeks after surgery, on the right side, the cancer was. Few months after surgery, and she had, as you can see, she had adjuvant chemotherapy. I think she was lymph node positive. And this is when she come for contralateral symmetry. And this is how she looked after symmetry. Another lady with central, because we can excise the nipple as well. If the disease is central, because central tumor, it used to be an indication of mastectomy before. This is the benefit of oncoplastic surgery. So this lady, she got just behind her areola on the right side, 50 millimeter high-grade DCIS. So she had central mammoplasty. This is when she come for contralateral side. And because she's happy with the other side, she decided to go ahead. Same, she just to have nipple losing because there is no indication to lose her nipple on the contralateral side, on the symmetry side. But because she is happy, this is where it start from here on the left, on the right, where she ended up. And she is quite happy. She doesn't want nipple reconstruction, no nipple tattoo. Because she's quite good in bra. The last lady, not the last lady, few ladies after that, this lady in her 50s, and she got 8 centimeter high-grade DCIS on her lower breast. So as I said, as with oncoplastic, now we have less indication for mastectomy. 8 centimeter disease, it used to be an indication for mastectomy. And because of she's macromastia, we decided to do oncoplastic, which is mammoplasty. And because of the nipple distance, not to the nipple distance, is quite long, and the nipple to the inframammary fold is quite long, it's going to be risky to put the nipple on pedicle. So we decided to have nipple grafting. So just, this is when we mark her because we have done the both sides on the same time. So this is her after operation with bilateral nipple grafting, which is life-changing to her. Vertical mammoplasty, again, we don't do it a lot like before because of the concept of oncoplastic surgery, because here the scar is like a lollipop with a small skin reduction and a minimal of uplift of nipple. Melon slice mammoplasty is, we can use it if there is a high risk to have wise pattern, because in wise pattern you got a risk of scarring, and especially on the T-junction where you got a lot of problem and skin necrosis. So if they are high risk to have wise patterns, the few slides I showed, usually we do what is called melon slice. I haven't got experience myself. This is one of my colleagues as well. So in the idea of melon slice, if the tumor in the upper half, what we do, we remove the whole segment. It's like a partial mastectomy, actually, just removing more than half of the breast, the whole upper segment, and then get the lower ball of the breast to be stitched to the top of the breast. So this is the lady and marking. She had once cancer on the right side, symmetry on the left. She's on table. This is when we remove the whole upper half, including the tumor, and this is the lower part of the breast. And then she stitched like that. And this is sometime after the surgery, few months, I think. That's it for me. Thank you.
Thank you, Muna. Thank you for your presentation. Very impressive and very nice outcomes as well. Thank you so much. Now we can listen to the panel if there's any questions or any points we'd like to discuss.
Yeah, thank you very much. Thank you very much, Muna. Very nice, and I like the diagrams, the drawn diagrams, more representative than having like pictures. Thank you very much. Very elegant presentation. Useful.
Thanks.
All right. Any further comments or questions? I can't see any questions on the online chat. All right. So in that case, we can proceed with presentations, and then we get the next presenter or speaker. That would be Mr. Ghassan. He's also a senior oncoplastic breast surgeon practicing here in the UK. And he will be discussing with us the topic of chest wall perforated flaps. So Dr. Ghassan, if you're ready to present and share your slides, please.
Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.
Thank you for having me again. And
Yeah.
I would like to thank all the presenters as well. Very nice presentations so far. Okay, so I'm Ghassan Lamin, working at Nottingham Breast Institute currently. And I'll just go through chest wall perforated flaps. As Mona mentioned, that nowadays it's used in replacing volumes for big excision and also for small incisions. And that's why, again, I agree with Mona, level 1. Yeah, for very tiny level 1, even nowadays we can put just Surgicel in that cavity and close the cavity on top of it, and it gives really good results. But a bigger than 15 millimeter kind of excision, I think you are mute, Muna, if you are saying something.
About Surgicel, I said to you, it's only on Nottingham. I haven't seen it elsewhere in the UK.
Yeah, I have seen it in Nottingham as well. I think this was Macmillan, Douglas Macmillan thing.
Yes. I have seen it in his presentation, yeah.
Yeah, and he does wide local excision from retromammary. So he goes from IM crease behind the breast to do his wide local excision. So he doesn't go on top or lift skin flaps or anything like that. Just going behind, do the wide local excision, put the Surgicel there and close. And well, like surprisingly, he's getting really good results. But now also Steve McCulley, who's also one of the pioneers in the chest wall perforator flaps, his new thing is to use very small L-tap flaps to fill the cavity. So that he doesn't use the huge, big L-tap flaps or LICAF flap, just small, as much as you need to fill the cavity. So he does his excision first, and then he decides the size of the flap, mobilize the whole L-tap vessel, and just plug the cavity with that flap. So this is his new thing. Now, definition for non-surgeon, a flap, of course, is a unit of vascularized tissue that you move it from one place to the other to fill a gap. And usually this is based on the vascular anatomy. So you need to know which blood vessel is supplying that unit to mobilize it with the blood vessel. And this unit or the flap can be pedicle when you just move it and leave the pedicle attached, that vessel attached to its origin, or free flap where you disconnect the blood vessel and re-anastomose it somewhere else. And the pedicle flap can be random, and that's like rotation flap. So if you know the blood vessel supply will be coming through this direction, you can just base your flap on that direction, move the flap around without isolating, visualize, or mobilize the vessel itself, or axial, where you find the vessel, mobilize the vessel, and put the flap. And that's what's done usually in the perforator flaps. Sorry. Tissue of the flap varies. You can use anything, but in the chest wall perforator flap that we use in the breast is mainly dermis and fatty tissue, subcutaneous tissue. So, of course, its survival depends on the perforators, and this is just a bit of history where it was discovered. Now, one thing about the skin is the vascularity. The skin is very vascular, and there are multiple plexuses, starting from the subepidermis, dermal, subdermal, subcutaneous, and prefacial. So there are many plexuses. That's why the thickness of the flap is important here. Besides, if you isolated the vessel supplying the flap, you better keep the thickness intact, the whole flap thickness, to ensure vascularity of the flap. Now the perforators, if we look at the cross section, the intercostal arteries and vein gives the lateral perforator, and that is the base for the LICAF flap, anterior perforators, and that's the base for the ICAP flaps, and the medial perforators, and that's the base for the MICAP flaps. And then on the side of the breast, of the chest wall, there is the lateral thoracic artery, and that gives rise to the L-tap flaps, thoracodorsal artery, and this is for the T-dap flaps. And of course, they all anastomose somewhere with the LICAP and the ICAP. So depending on this and the location of your cancer, you decide which flap you are going to use. Selection of patient depend on the cancer size and location, if it's suitable or not. Does this patient need to have a flap or not? And one of the concepts is to avoid the flap fever. So you don't have to do the flap just because you know how to do the flap. Sometimes this simple procedure is much better than doing too much. So cancer size and location, patient health and comorbidities, you better avoid complex procedure in comorbid old ladies with like smokers. And patient body builds, very slim patients, you might not find enough tissue. You will end only with like a skin without fatty tissue, and therefore you better look for other options. Breast contours and symmetry. Sometimes your patient has asymmetry from the start, and that therefore you might need to avoid or to go to other option like mammoplasty for symmetrization, or to use both mammoplasty with flap. So that you don't have to end with the same asymmetry, just like putting patient back to the same shape and size. This might be a chance for the patient to correct the symmetry. And also patient preference. What the patient want. Like this lady who had bilateral DCIS in the outer part. So I offered her two options, either doing a racket handle or tennis racket mammoplasty on both sides, or to do chest wall perforator flap again on both sides. Explain to her, of course, with this one, it will be a little bit lifted and smaller breast. But she decided to go for the flaps because she wanted to keep her breast same size if possible. So patient preference comes also in the process. And yeah, avoid the fever and remember case which is keep it simple and stupid, which is the best option. Now flap marking, some units use Doppler, we do now, or others just go blindly because they know the perforators will be there. Most of those who are used to do light cap flaps, they go blindly because light caps are always there, and you don't have really to visualize them or to isolate them. Different schools of marking. You can just go horizontal or go oblique. You can have the S shape or use the whole flaps, like different styles, and everyone can modify what they are doing. So there is no fixed rule and no even for myself, like I changed along the way of what I'm doing. One thing to remember in the marking is the pivot point, and this is the most important part in doing the perforator flaps. Always remember patient when they are lying down and they are under the anesthesia, most likely their muscles are relaxed and their breast is falling to the sides. So what you do and the flap you are putting will change shape and position completely when they stand up and when they regain the muscle contraction. Therefore, when you are marking the patient, you mark them while standing. You need to remember your pivot point, which is where your flap will move. So this is the L-tap. After saying use the Doppler, I know my L-tap is going down that way. My cancer is there. I have to make sure that the length of my vessel from the pivot point is equal or longer than the length of the distance from the pivot point to the cancer. And remember, it's a three-dimensional, so you are going in and forward. So less than that, it will be shorter. And you might still use the length of your flap because you'll flip it around. But this concept is very important to remember when you are doing a flap. That's for the L-tap. For the light caps, your pivot point is here. It's very short pivot point. And therefore, in the L-tap, in the light cap, usually you will need longer flaps. And you will need to remove all the breast tissue here up to the edge. So you need a bigger flap for the light caps. And again, this length from your pivot point should be equal, if not bigger, than the end of like the inner part of your wide local excision. Now, as I said, one thing I changed recently when doing the marking, I drew both. Like if I have the L tab, I'll use the small one because I don't need that big. But if I couldn't find the L tab or I damaged the L tab, then my like cap is here and I use the long, bigger one. And I'm doing that now because, as I said, Steve McCulley is using small flaps for that, and he does that intraoperatively. He decide, but just to avoid the unplanned shape of scar changing intraoperatively, I just plan it earlier before surgery. Which do I use? And it worked well for me. So this lady in the picture, she presented with this cancer in the in the left upper outer quadrant. She went for chemotherapy, and this picture is actually post chemotherapy. And so the marking, I mark first the footprint of the breast itself. Just to save time, I'll keep pushing. This is the cancer where there is some skin dimpling. I'm going from the IM crease using that fault. This is a very old patient of mine. At that point, I wasn't using Doppler, just blindly drawing the flap. I like the curved kind of marking rather than straight line to avoid the dog ears. And then if you notice here, I didn't go big, even though the excision is big, because she has a really good fall. So I can recruit more tissue by undermining some of the fatty tissue. So that's the lady, and this is my excision will be that big. Now, intraoperatively, the same lady, I used to do the de-epithelialization first, and then I do my wide local excision, SMB, and after that I go for the vessels. But nowadays, as I said, because of my planning, I find the LTAP first. And following finding the LTAP, I go for the excision and the SMB, and I go for mobilizing the whole LTAP to the pivot point. Because at that point, I have to decide, am I using the LTAP or going for the LICAP, and that will affect my de-epithelialization. But this one, old, I did the wide local first, then the SMB, and I go from under the breast. Many surgeons, they go along the LTAP. They find the LTAP and they go along the LTAP to find the sentinel node biopsy because it's always sitting beside the LTAP. And after that, they come back for mobilizing the flap. So doing the SMB, now finding the LTAP vessel, mobilizing the LTAP with a cuff of fatty tissue, and the whole flap is mobilized. Then I do this tunnel. Usually I call it Goddard tunnel because it's one of my assistants. She's similar to Nels, like ACP. She was assisting and asked me, why can't we push it under the breast? I said, yeah. And since then, I'm using this tunnel, and I called it on her surname is Goddard, Lucy Goddard. So it's Goddard tunnel, pushing the flap inside, put it in place. Very loose stitches. You don't want to put like secure stitch and to close every space between the flap and the breast tissue. Because remember, breast tissue is mobile. When they stand, it will change shape. You want the flap to sit where it should be sitting rather than where you want to put it. So the loose stitching is just to prevent it from falling back. And actually in Nottingham, most of the surgeons, they don't put stitches at all. As long as your flap is loose, like there is no tension, the flap will sit there and it will go nowhere. And then with the movement and using support bra to mold things in place, the flap will sit nicely and heal very well. So very loose stitching, and this is the closure of the skin. and that's the lady post-operatively. This is the lady we gave options for either flap or racket handle, and she has chosen flap. This is her mammogram, DCIS on both breast, marked. So just calcification, I think 3 centimeters, about 3 centimeters in both sides. And this is her wide local excision. Intraoperatively, the marking here, we use like an lazy S-shape kind of marking to do the procedure while she is supine. Little bit of a lift. Usually in these flaps like cap or L-type, patient is tilted to the side, or it's done all on the side position. But in this case, because we were doing bilateral and this is unusual, she was supine, we use a bit of lazy S, and both sides were done simultaneously with another surgeon. So deep sterilization, again, excision, finding the vessel, mobilize the flap, put it in place, closure. And that's the lady post-operatively. This one is a lady with retroareolar cancer. The cancer was small, but it was very, like it's just behind the areola. As Muna said in the past, this used to be, especially with this such small breast, used to be an indication for mastectomy. So for this lady, I decided to go for a ICAP flap and using some of her skin. And at this point, I had a Doppler, again marking the footprint of the breast. With the Doppler, I found the 3 perforators, my cap and 2 I caps. Of course, you can go up to the lateral for the light caps as well. You can use it as well, like in reserve, so reverse pattern. For the marking, I go about half to 1 centimeter above the IM crease. And then my marking, I try to avoid going beyond the edges of the breast, the medial and lateral edges. And I use kind of straight line rather than crescent on both edges. And nowadays, even in the lower part, I go a bit of convexity in the lower part of the flap. So the central excision, we need to remove the nipple and areola here with the cancer, and therefore I wanted to keep this skin island of tissue to fill that gap. So that's the marking of the lady in theater doing the usual, the deep sterilization, but leaving this tissue and simultaneously doing the wide local excision. I don't know why I have too many pictures. Good. So this is the wide local excision. And then using this Alexis retractor, which give me good view, I did the SMB through the same incision. It's easy when you are using dual technique. You use the gamma probe, you can find your sentinel node biopsies and remove them. Then the mobilization of the flap. In the past, like the way I started learning the perforator flap is by doing kind of random flap. So I keep the dermis intact in one side, mobilize the flap and just flip it around without finding the vessel. And gradually I started to look for the vessels. And this happened during the COVID, which was good time to do all this because at that point they stopped doing oncoplastic procedure, just go for simple procedure to avoid prolonged anesthesia, and theater time was precious. So at that point, I was doing too many of these random rotational flaps, and gradually found the vessel and then started to disconnect the dermis. And therefore, I do have the habit till now of keeping this as a second, like plan B, if I couldn't find the perforator. It's of no use. I have never done this, like keep the dermis for the last 5 or 6 years. But still, it's good to know there is a plan B behind. So mobilizing the whole flap and recruiting some because I wanted to have some tissue to go under my uh, skin island there, just to keep it, to level it with the skin. So I recruited more tissue laterally, and it does survive. People don't tend to do that, but I think undermining, especially in healthy patient, is good. Finding the vessel, this is one of them, and then mobilizing the whole flap, pushing it under, and all this tissue I recruited, I put it under the skin island to keep the flap on top. That's the same. Yeah, that's the flap sitting and closure. This lady, I remember she was a smoker. So she did have some wound problem, like a small dehiscence there, and also big seroma. Following this case, I started to put drains via the at the donor side of the flap. Another one, similar case, but no skin island. This is the excision, and that's following the operation. This was a very, very challenging case, and looking back, I would never give flap. So this lady is a very thin lady. Again, that's why I said body habitus is important. She does have a small cancer, and I think this is an ideal case for Syrgicel, just to fill the gap. But at that point, probably flap fever. I did the flap, it worked well, but I did bend the skin here while recruiting. This is after 2 months. I do have picture for her after 2 years, and it looks really good, but I didn't upload them. Another case, this young lady, again, big cancer in the lower breast. She didn't want any mammoplasty. She wants to keep her breast look. So the flap depolarization, as I said, nowadays I do a bit of convexity here, and that help in keeping the IM crease in place. I never repaired the IM crease. Many people recreate the IM crease when they do this ICAF flap, but I never needed to, and it's working fine. So this is the excision and the flap mobilization. Again, I'm keeping this as a backup, but once I found the vessel, I'm not sure if you can see the vessel there, all mobilized, the flap lifted, put in place. I did the SMB through the same incision. It's very good for the patient, like pain-free and all that, but it can be challenging. In this lady, I had a significant bleed. I think I injured her L-tap while doing this. We needed a lot of effort to stop the bleeding. Eventually it worked. So if you are, it's a bit risky. So if you want to take the risk, yeah, that's fine. Patient will be happy. Left a drain. She was very bruised after, but she had a very good cosmetic results. A lady with multifocal cancer. They both are small cancers, but they are connected to each other. So the area to excise was big. And from the start, the lady had, so this is the marking. She had a smaller breast on the right side. I offered her mammoplasty at the time of both sides to get the symmetry, but she didn't want that. She didn't want to touch the normal breast and wanted just to keep things to single breast. So she is not an ideal case because she is ptotic. The more ptotic the patient is, the less um, cosmetic results. So they will not be as nice as grade 1 ptosis, like 0, 1, or even 2. But when you go to grade 3 ptosis, these are not ideal for perforated flaps unless you are doing just a small L-tap flap or T-tap flap, like you are mobilizing them, plugging the hole. So she had the 2 wires, and again, a bit of convexity here, there, and there. This help in the closure and avoiding pulling the IM crease down. She was an auxiliary, not clearance, therefore another incision. I'm not that brave yet to do clearance through the same incision. So in this case, I deglove the whole breast, lifting the nipple areola and the skin. And then this is the area to excise this big area, so almost half of her breast. That's the specimen after inking, and big flap, mobilizing it, depending on a small vessel. These perforated vessels are small, but they are more than enough for the flap to survive, making sure it reaches where I want to. Again, Goddard tunnel, pushing it from under the lower tissue, leaving it in place. I don't think I have put any stitches here, just put it there. Closure, 2 drains, one in the donor side and one going to the axilla, and closure. This is post-operatively. She gained more volume than what she has, so the breast is now closer to what she had initially. Some blistering, but there was no necrosis eventually. So these are examples of the flap, and they can be really good, but I think the best thing to do while doing these flaps is to reflect what went wrong, what went right, what I can do better, and that's how we improve. So, like this lady, she had this cancer, again upper outer quadrant, good volume cancer. But as I said, this lady, first of all, she's very ptotic. So this is grade 3 ptosis, not an ideal candidate for perforator flap. Still, I went for the flap. Again, she was offered the mammoplasty, but she didn't want the mammoplasty. She didn't want to touch that side. So opted for the perforator flap and L-tap. And I think you can see clearly what's wrong here. Pivot point is there. The very short L-tap, I could have gone lower to get my pivot point in the right side, but I just left it there. This is very short to reach. When she was lying down, I corrected that little bit, but still it's not enough to fill that. Deep visualization and excising, finding the vessels, mobilizing and closure. So patient is lying down, looks fine, with no problem, happy with what I have done. You can see a bit of pull even while she is lying down. And now this is when she stood up. You can see it clearly here. It's all pulled up. And even without being that short, doing the wrong pivot point, the length of my LTAP, still as a totic patient, this is not ideal. Even if you did it the right way, it will be like a lump sitting up there in the empty breast. So patient choice was wrong, marking was wrong as well. This is another lady, same thing. I was doing clearance here, so I used like a lazy S shape kind of flap. In many patients, that worked well for me, but you can imagine if the cancer is here and my short L tap, this will not sit good. Procedure done, and you can see the pull. So her nipple is looking out now. Another lady with lower central. This was unnecessary, like very small cancer. She didn't need a flap, but because of doing the flap, she had an empty area in the IM crease. With arms down, she's okay. Arms up, you can see the emptiness. So she wasn't ideal for this kind of flap. And again, this one could have done with a Surgicel only. This lady, I'm sure this was the flap fever because just well prefer the flap fever. She has mastectomy on the other side. Why am I doing a flap on this side? She has a small cancer. I could have just done, if she wants to keep her breast, just a vertical mammoplasty, slower central, again, the same problem. It's not a nice breast and better to avoid. This one I learned a lot from. So I did everything the right way, marking, even though it was high up here. Like you can see, the pivot point is not right for her, but I changed that in theater when she was lying down. I changed it, I lowered it. But intraoperatively, I found the LTAP and mobilized the whole LTAP, but also I found the lie cap and I kept the lie cap intact. And then I found a TDAP that I can release. And I did that. I left it in place. I didn't mobilize it the whole way. Flipped the flap over, put it in place. It looked really nice because patient was lying down. And then once she went to recovery, to my surprise, the flap retracted backward. So there was this gap, empty area. Post-operatively, she was fine, but there is a pull in the flap. Like after about 3 weeks when she came for the results. But the lesson learned is never change your plans unnecessarily. So I had a very good LTAP. I don't need more. Why keeping the lie cap and a TDAP? Even if it can reach, there was no need for that. I should have kept my LTAP, and that could have given her a much better cosmesis. So that's lesson learned. Plan well, choose your patient, the right patient, plan your procedure well, do the marking, bearing in mind the volume you need, the perforator you need, the pivot point, and then stick to your plans. Unless, of course, surprise happened during intraoperatively, but otherwise, stick to what you plan. Don't change plan or you might suffer consequences. Thank you.
Thank you very much, Dr. Hassan, for the very nice and delightful talk. Now we can open the door for questions and discussion.
Thank you, Hassan. Really, really brilliant presentation. I learned few points. Number one, because I always recreate IMF when I do my cap and ICAP. So I will try to do this curvature as you suggest to avoid putting more stitch, and sometimes it pull in when you see the ladies post up. So this is number one. Number two, putting drain, because usually in our unit we don't put drain, but I get a lot of seroma, especially with LICAPs. LICAP, you got a lot of seroma. So I think it is wise to put a drain for 1 or 2 days. And also reflection. So yes, we need to go back and reflect in our practice. So this is what I learned from you. So I need to go back and see all cases, what I have done wrong, what I have done right. And for the pulling of the flap, I think, in my opinion, do you think it is short flap? This is the reason why it is pulled back. Your case is the last case is the flap is pulled back. So do you think because it is short, I think in my opinion, it is a little bit short to the position of the tumor.
I don't think the flap was so, as I said, the marking I have changed it already. So that picture I took, but when in theater I lowered it to keep, just to make sure my L tap is long enough. The flap was more than enough to fill the cavity. When I put it over, it was sitting very nicely in place. I didn't even put any stitching. And maybe that was one thing, because I just left it in place. It was sitting fine. I did the closure, put my drain. It all was good. But I think the problem was the T-dab that I left, because the T-dab comes through the thoracodorsal, the LD muscle.
Yeah.
And because I did not mobilize it, like when you do a T-dab, you have to mobilize it, separate it from the muscle, even cut muscle fiber to reach the thoracodorsal itself, and then separate the descending branch of the thoracodorsal. In this case, I did not. I felt things are sitting fine. Therefore, once the patient was awake, her muscles contract. I think they pulled this T-dab and pulled the whole flap back where to the length. That's why I think I should have just left it with the L-tab or even the LICAP. I had LICAP, L-tab, but I think I just wanted to impress or something. But that was the wrong decision. Regarding the drain, I think, as you said, you do recreate the IM crease. That means you are closing the dead space, probably. In that case, it's less likely you need a drain. But because I
No for
don't,
LICAP, not for MICAP or ICAP. Yeah, I recreate
okay,
IMF for ICAP and MICAP, and to be honest, I got a good results. But
even
some,
for
but not for
LICAP,
LICAP, I get a lot of I don't got seroma for anterior perforated flap, but for the lateral, I get seroma. So,
so what they do in Nottingham, they also close the dead space and they use even the muscle, so stitching in the subcutaneous and taking the muscle as well,
it's like
part of the muscle.
quilting, something like that.
Something, yeah, like that. And that brings things together. But me personally, I feel this might give patients chronic pain or something. That's why I don't. I just close the skin and leave a drain. I always leave a drain.
And
Thank you, Ghassan, for this
trauma.
very. Sorry.
Just last
Marcel.
point for the anterior flap, you said you put the incision at IMF or above IMF, the top of
Above,
the above IMF,
above,
so as not to have
yeah,
it lower post operatively, is it?
yeah, because there will be pull upward and pull downward. So it's just half to 1 centimeter, depend on how
Above
big. Yeah,
above IMF. Okay.
above the IM crease.
Yeah. Thank you.
Thank you, Ghassan, for this very informative presentation.
Thank you, Mr. Omar.
Do you think if you don't have an ultrasound, you could do those? Now, after doing this for a long time, do you need to have a
The Doppler.
ultrasound, a Doppler? Sorry.
Yeah, it can be done easily. The only thing is just to avoid surprises and actually to make things faster. The Doppler, especially like when I started I started with the rotational, keeping the dermis intact. Then I started to find my vessels without Doppler. I didn't have any Dopplers at the time. But then we bought Doppler in our institution, the hospital. I used to be at Sherwood Forest. And I started to use the Doppler to mark the vessels. And then I started to use the Doppler intraoperatively. And that makes things faster. So you don't need to see the vessel, you know it's there. And that
Okay.
can be very fast. But then when I moved to Nottingham, now we use the Doppler for marking and we don't use it intraoperatively. However, it takes longer time. Therefore, I just decided to go back to the Doppler. It's just to save time. But it's very doable without even marking, especially if you are doing LICAPs. LICAPs are there. They will be there. You just mobilize your flap. If you didn't see them, you didn't cut them, you got your length enough and sitting fine, you can check the viability by just, I cut the end of the flap usually, that tip of the flap, I cut it with scissors just to see the bleeding, and also because it's high risk of necrosis, that tip, and that's it, it will sit fine.
Excellent. Thank you very much. Very informative.
So just Ghassan, I noticed in some cases lateralization of the nipple. So flap sitting nice and everything, but sometimes there is lateralization of the nipple. And I did ask this question before in courses, and they said the best thing to prevent or to reduce the risk of nipple lateralization to do like complete mobilization of the whole skin of the nipple areola complex, and to do lax lateral incision so as not to be pulled by incision. Have you got any experience about lateralization of your nipple in your cases?
Yeah, I used to do that, like to separate the ducts completely from behind the nipple. But also it all has to do with the pivot point, really. So you have to make sure of two things, like when you are doing the marking. When you are doing the marking, pinch like a closure just to see that affecting the skin itself, because the skin itself can have a lateralization issue. So if you pinch the skin and the nipple moved, then your marking is not right. You need to change the direction of your marking. And also the flap for besides the pivot point for the LTAP, the pivot point for the LICAP. LICAP can reach even the upper inner quadrant if you want.
Because you can make it longer. Yeah, exactly.
You can make it longer, but you have first of all to remove the breast tissue up to the edge, because putting the LICAP on top of breast tissue, that will reduce the length of the flap, or even under. It will make a bulk there. So ideally, use the whole LICAP to fill the whole strip of tissue up to the cancer side. And intraoperative, you can even use the ruler or use, if you have the pack, the big pack, they have these tapes. Back, you use it just to see
the length,
to check is that length enough. And of course, you want the length to be a little bit beyond your excision, so it relax there, sit nicely without any tension, and that does help. But sometimes you will still end with, because of scarring, you will still end with some lateralization.
I think it's good trick to do this skin bunching and pulling a bit back laterally to see if there is any nipple change, and then you can change. I think this is good trick. Yeah, thank you.
Yeah.
Again, thank you very much, Dr. Ghassan, and thank you, dear participants, for the enriching conversation and discussion. Next, it's a great pleasure to warmly welcome Dr. Hassan Riza, a distinguished oncosurgeon, to share his valuable experience with us. We are honored to have you present this interesting case from
Hello everybody. Good afternoon. Dr. Hassan Riza from Afghanistan. I'm working in NCCP Hospital, Kabul, Afghanistan.
Bringing insightful.
Excuse me?
You're very welcome.
Do you can show the
Insightful
slides?
perspective. Okay, I'm going to share your slide. Can you hear me? Dr. Hassan, can you hear me? We can hear you.
Yes.
Okay,
I can hear you.
you're welcome.
I think there is a time lag, so that
No problem. My case presentation is very short, about 10 minutes. Yes. Thank you.
so
The
maybe
next slide.
Dr. Hassan, maybe you speak a little bit about the hospital. It is the main oncology hospital in the country, correct?
In Afghanistan, it is the first hospital which is established in Kabul for oncology. Yes, it is one of the most oncologic center in Afghanistan. It established about 3 months ago, but the program of oncology in National Cancer Control Program with Jamhuriyat Hospital in center of Kabul. In 2016.
Okay, but
Yes.
Ibn Sina Hospital was established in which year?
Then transferred to Ibn Sina Hospital for 1.5 years. Then transferred to a new hospital, which is especially for oncology.
Good. I just want to mention that there in Afghanistan, they have this wonderful work that the surgeons and the medical oncologists work together. So you have the surgery departments, 1 or 2 floors, and you have the oncology departments, and they meet, and they, not like in Sudan, we used to have in a different hospital.
Yeah, NCCP hospital is in 5 floors. The 5th floor is surgery department, and first, second, and third floors belong to medical oncology.
Good, thank you.
Yeah, next slide. Next slide. Can you help me? Yes. Case is belong to a woman, which her name is Aim Khal, from north of Afghanistan, province of Kunduz province. Yeah, ethnicity is belong to Tajik. Yes. Yes. Next slide. The patient had left breast lump 4 years ago. She was operated lumpectomy 4 years ago in Kunduz province, provincial hospital, but without any pathologic examination, unfortunately. Next slide. Yeah. She is suffering from recurrent mass on her left side chest wall since 6 months ago. The mass became larger and painful since 2 months with odor and ulcerative ulcers. It became fungated since 1 month before last surgery. Yes, next slide. Yeah. In physical examination, there was a huge mass started from sternum up to latissimus dorsalis, and from first rib up to 6th and 9th ribs. very huge mass. Next slide. Next, yes, it is the image of mass, ulcerated and fungated mass, very huge. It started from sternum up to latissimus dorsi, and from second or first rib up to 8 and 9 ribs. It is located under pectoralis major, which infiltrated to left breast. Next slide. Procedure we did for her toilet procedure. She candidate and admitted to NCCP hospital for toilet procedure, mass excision, mastectomy, and axillary lymph nodes clearance, because in CT scan report there was many lymph nodes in left axillary fossa without any metastasis to bone, lungs, or brains. The main origin of mass was from chest wall muscle under pectoralis major. Maybe from intercostal muscles. After toilet mastectomy, the wound partially closed and clean dressing done. The second, excuse me, next slide. Yes, it is the team of surgery in operating room, surgeon, assistant, scrub nurse, and anesthesiologist. Next. Yeah. Dr. Nahla.
Yes, I want to
Yeah.
I want to ask you, how many kilos is that? It's huge.
Do you know me? It is the sample very large, very great. After surgery, my foot is colored with blood, unfortunately, because during the surgery there was very bleeding, about 1,000 cc. Next.
And the mass itself is how many kilos? Is it 1 kilo?
About 3.5 up to 4 kilos.
Wow.
Maybe
huge.
more.
Huge.
It is the surgical side. The wound is closed partially from left shoulder up to about 8 or 9 ribs. You can see here is gases under wound, which is not closed. Next slide. Yes, it is the report of pathology. Pathology reported that that it is compatible with inflammatory myofibroblastosis tumor, which is need for IHC for good investigation and more definitive diagnosis. Next slide. Yeah. Pathologists said yes. Unfortunately, we don't have IHC examination or pathology laboratory in our hospital, in governmental hospital. for doing IEC and other investigation. Just histopathology exam is available in governmental hospital. We need to do another examination for more investigation in private laboratories. Because of this reason, the relatives don't do this examination. Because of this reason, our work is not complete for breast cancer, also and other cancers. Next slides. Yeah. About 2 weeks ago, I called for patient relatives, and I asked them that how is the situation of patient. They said that her situation is very good. The wound became closed, and there is no ulcer, no mass, and no any problem. But they didn't receive the report of pathology up to now because they don't do this work because it is a kind of insouciance. In English language, insouciance. In Persian language, betafauti.
What does it mean? I don't understand you.
Defiance or audacity, kind of audacity. It is a kind of mode between Afghan men, unfortunately.
So they don't.
Yeah.
There is a cultural barrier, or what? I don't understand.
Unfortunately, yeah. Unfortunately, yes. They waiting for recruit of mass. When the next time the mass became larger, will be became for receiving of pathological. Yes.
Okay. Good.
Next. Thank you.
Thank you, Dr. Hassan Manawi.
Thank you so much.
I want the surgeons in the group as well as the pathologists to comment about this case. Myself, I was impressed about the surgery. It looks so clean. If you can show that slide, I think it's number 7 or 8 after the surgery. Yes, this one, number 10. I didn't think this is of the patient. I thought this is a mannequin or something, but it's.
Thank you so much.
Let's see the surgeons and pathologists. What do they think?
You. But from the pathologist, what is myofibroblastoma? Is it something from the muscle, or we don't? Pathologist Nadia.
Yeah, I'm here.
What is myofibroblastoma?
I think I myself have to check what that is because to me that looked really a malignant tumor.
Yeah, it is look malignant, is quite big, quite large, and in my opinion, they have done a good surgery. But if my cursor here moving, can you see my cursor? So if you go down towards the muscle and towards the abdomen and do more mobilization, so we lift the skin of the anterior abdominal wall muscle, it might give more space of closure. We do it sometimes, we call it abdominal advancement flap, if we like to have a good closure of the whole chest wall, if there is such big tumor like that. So we go more down towards the abdomen and make it like rotational flap, actually, rotational flap, so as to close. We mobilize the skin in the abdomen, we rotate it to cover the chest, and then close the skin in the abdomen and in the chest as well. So you're going to have like a good closure. But it might be, because it's too big, it's too huge, I don't know if this is going to work or no.
Dr. Hassan, did you do chest X-ray, abdominal ultrasound, any staging investigation?
Staging, yeah.
Before surgery, the patient had a CT scan, chest abdomen contrast enhanced CT scan, which there was no any metastasis to bone or lung or abdominal organs. Just multiple lymphadenopathies in axillary left axillary side, which we cleared all of them.
I think it is benign tumor.
It is, yes,
It's been like fibromatosis. Before I thought it is the
yes,
same like fibromatosis, but it behaves less aggressive than fibromatosis. It is more well defined than fibromatosis, though
yes,
the
and
origins is the
it
same.
doesn't metastasize.
It is a stromal type of tumor, but it is
Yeah.
more well defined and it behaves as benign. That is why I think the lymph nodes are negative.
And no
Because
metastasis.
it is not a malignant one.
If it is
Yes, this is not
malignant by this
malignant,
size,
actually. Yes, I agree. I totally agree with you.
It
This is not malignant. This is a benign
It is
disease.
a desmoid tumor.
Yes, but it looks like malignant from the initially. Maybe I don't think maybe it's fungating, something like that, or ignored
Yes,
for
it
a long
really
time.
looks malignant, yeah.
But it is a benign.
It might become, because it might become very huge, very large, result in local ischemic changes, ulcerations, and become fungating like that. From mass effect, probably.
Distant metastasis, Rabab, if it is malignant, aggressively malignant, should metastasize to the body as well?
Yes,
It doesn't.
It is malignant?
No.
No, it doesn't.
But the question, why it recurs? Because this is like 4 years before, there is the surgery on the same side. I don't know, maybe different. Maybe 4 years back, maybe different from this. I'm not sure.
Because fibromatosis as well, it recurs. It is benign, but it is aggressive and recur, and it has the same cell origin as fibromatosis. I think that it behaves the same as fibromatosis. It can recur. Maybe.
Yes, excuse me, because what is your opinion? What are your opinion about this case? What should we do for follow-up and for IHC? Is here need for doing IHC?
The immunohistochemistry.
Yeah.
I think since it recurs before, it needs to be followed. Yeah.
It can. Yeah.
And
I should call for relatives every 3 months, yeah?
Yes. Yes.
Yeah. Yeah. Thanks. Thank you.
Clinically and by imaging.
Also by imaging, yes.
أهم حاجة يا دكتورة، أهم حاجة يا منى، شفت الإيميجينج ده؟ أهم حاجة ندخل روحنا. لازم إيميجينج ما كلينيكال براو.
Which modality of imaging is good for this patient?
Start by ultrasound. I think here ultrasound, it will help much more. If there is something questionable, then you can proceed for MRI. I think the role of mammography would be low in such case.
Yeah, mammography. Yeah.
Clinical examination also. So, Dr. Hassan, it's not only that you ring them, but you need to see the patient and examine the patient.
Yes.
Yeah. Physical examination is better, yeah.
Yes. And I think there is a new oncology center in Kunduz, no?
Up to now, no. Nangarhar, yeah.
Because the place the patient is very far, like, is it 400?
About 300
kilometers
up to 400 kilometers far from Kabul. Yeah.
And sometimes
north of Afghanistan, near to Tajikistan. Yeah.
Sometimes in winters they cannot even travel at all.
Yeah, I called her relative, but they denied from more report about this
Okay,
patient.
so you need to tell them, I think this is important, you need to tell them that she doesn't have cancer.
Yes.
I think
Yeah.
they don't want the stigma of cancer. So you tell them we discussed it.
It is a very good news for them, yeah?
Yes, yes. You tell them this is not cancer. We discussed it in an international meeting, and it is benign, but it has a tendency to recur. We have to follow her closely.
Yeah. Thank you, teacher.
Good. Any other comments?
I think it just adds, it is like this benign, it just pressure effect on the, because of the size of it, that the pressure effect making this breast or the skin look like quite necrotic. It just pressure effect rather than neoplastic effect.
Yes, I agree with you.
Yeah.
That is why I raised that suggestion. Yeah. It is pressure effect causing ischemia and resulting in ulceration and infection.
Yeah.
And I also want to mention that if it was malignant, this wouldn't be the condition of the patient. Like even if it is adenocarcinoma or sarcoma, the patient will be like, she cannot grow this mass and be surviving yet, you know? It's huge.
Yeah. Yeah, interesting, very
About
interesting.
4 kilograms, yeah? It's weight about 4 kilograms.
Huge. Thank you, Dr. Hassan, for your contribution. Welcome to join us in coming meetings. It's great to have you.
Thank you, my teacher. Thank you, my teacher.
Thank you again, Dr. Hassan, for the excellent presentation. We truly appreciate the way you enriched our knowledge through your expertise and education in the field. We look forward to more engaging and informative sessions with you in the future. Next, دكتور معاوية، هل أنت معنا؟ دكتور معاوية؟ It seems like Dr. معاوية is not here yet. Next, we'll stay with update on oncology management with Dr. Nigla Jafar.
So if it is Nahla Jafar, I'm not ready yet. You said 4:30, correct?
I'm sorry.
Or you meant Nada Nigla Saad?
No, نهلة جعفر.
نهلة
نجلاء
جعفر.
سعد. دكتور نجلاء موجودة معنا؟
No.
I can go for my presentation.
Yes, please, Dr. Amin. Thank you.
Yes.
Thank you, Dr. Amin.
Yes.
Dr. Amin Tijani, consultant, medical oncology, Prince Mohammed bin Abdulaziz Hospital, Ministry of National Guard, Health Affairs. Please be our guest.
Assalamu alaikum wa rahmatullah. First of all, I would like to thank the organizer for inviting me, and special thanks for Dr. Rabab for this successful meeting. So my task is to speak about the systemic therapy of the primary or early breast cancer. So breast cancer actually is not a one disease. In the past, we think that it is only one disease, but currently it is a biologically diverse spectrum. It remains potentially curable, but the risk of recurrence is there due to micrometastatic disease. And we know that systemic therapy is the cornerstone of improving the long-term outcomes and survival. And the decisions are increasingly driven by multiple factors like tumor biology, including the hormonal receptor status, HER2, and also the genomics is very important. The clinical risk also is very important, tumor size, nodal status, and also patient factors is very important in the management of breast cancer. So if we are going to go through this stepwise approach for the treatment of early breast cancer, as I mentioned, to define the subtype, which is very important. Is it hormonal positive, HER2 positive, or triple negative? And then to assess the risk of the clinical risk by tumor size, nodal status. The grade is very important, also Ki-67. And also we have the genomic assays like Oncotype DX and the mammoprint to decide about the treatment. Timing of treatment is very important to give it neoadjuvantly or adjuvantly. When we look to the breast cancer clinical subtypes, we know that estrogen receptor positive account for like 70 to 80% of cases, HER2 positive around 15 to 20%, and this is divided by ER positive and ER negative, and we have the triple negative, which is about 15 to 20% of cases. As I mentioned, neoadjuvant therapy, there is certain indications for that, but definitely all these cases needs to be discussed in a multidisciplinary team. It's mainly for those with triple negative breast cancer, HER2 positive, and also large tumors. This is where the new adjuvant is indicated. And the advantage of that is to downstage the tumor and to have the pathological complete response assessment. Adjuvant, as we know, it will be given after surgery, and this actually based on the pathology and the response to previous therapy if given like neoadjuvant therapy. This can say the same things that we need to tailor therapy by the ER and the HER2. And as you can see here, for triple negative breast cancer, we have chemotherapy and immunotherapy, either given like neoadjuvantly mainly, or sometimes adjuvantly. For those with HER2 negative and ER positive, the main corner of treatment is endocrine therapy, but chemotherapy may be given for some cases. I will come for that. HER2 positive breast cancer, the anti-HER2 is very important, and the chemotherapy also needs to be given for all patients. And if we have a triple positive disease, we can give all this endocrine, chemo, and anti-HER2 treatment. If we look to the intrinsic subtypes, and this is, as you know, we have luminal A, luminal B, and HER2 enriched, the basal-like. And we can see here the prognosis, and we can see this is the relapse-free survival probability. And it's very clearly that luminal A is the best prognosis of all these subtypes, and this is followed by the rest of the, including luminal B, HER2 enriched, and basal-like. When we look to the breast cancer outcome, and you can see here in this is 2A and B graph. If you look to the from 2004 to 2008, looking at the hazard rate of relapse, it is improved. It is greatly improved when we compare it with this in the A, which is from 1986 to 1992. And this is for actually for all subtypes. And this is because of better endocrine therapy, development of anti-HER2 therapy, and other targeted therapy. What about the impact of chemotherapy, which is the cornerstone of breast cancer, and since long time? You can see this study from Lancet in 1992, and it showed that the reduction of early relapse, and it is around 5% absolute difference for up to 5 years. This is with polychemotherapy regimens given mainly as adjuvant or neoadjuvant. After 5 years, the reduction will be less, like 1%, which is non-significant. So we are getting benefit early in the first 5 years of treatment. We know that we have multiple chemotherapy regimens. We have the older one, and we remember that when the CMF was used, and AC protocol and AT, which is less effective when we compare it to the more modern and effective therapies, which include the anthracyclines and taxane, and given in different like dose dense or weekly therapy. So the modern therapy is more effective than the older one. What was the major chemotherapy advances? Actually, when we can look to this, the addition of taxanes is one of the major advances for early breast cancer. And we can see here in the higher graphs, we can see adding paclitaxel to anthracycline-based chemotherapy in triple negative improved the disease-free survival. And also, one of the important major chemotherapy advances is the dose density. Well, and dose density, usually when we are giving the medications with the same doses, but given more frequently, and this is with giving the gross factors like giving GSF in these cases. When we look to this trial, which compare adding anthracycline to the taxane, and we know that anthracycline they have the toxicity which is associated with increased risk of congestive heart failure and also leukemia and myelodysplastic syndrome. And if we look to this study, the outcome of this study with regard to invasive disease survival, you can see here there is different, like 2.5% favoring adding taxane to anthracycline-based chemotherapy. And this is actually mainly, you can see it in triple negative disease and in ER positive with if they have node positive. But in some cases, if we have a node negative disease, so the benefit will be less. And in these cases, we can give taxane-based chemotherapy without giving anthracycline and increasing the toxicity of the chemotherapy. So let us go by these subtypes and to see what are the treatment for those subtypes. And I will start with the hormone-positive HER2-negative breast cancer. As I mentioned, it is the most common subtype. The backbone of therapy is mainly endocrine therapy. And the key drugs are tamoxifen and aromatase inhibitors, as mentioned earlier in presentation. Duration of endocrine therapy for the early breast cancer generally from 5 to 10 years. And the role of chemotherapy in this subset of hormone-positive breast cancer is for high-risk cases, with those also having node positive and high genomic risk. Genomic assays also include Oncotype DX and MammaPrint, and these genomic assays also guide us for chemotherapy decisions. Despite treatment advances in breast cancer, actually the recurrence remains a challenge in the early setting, especially in this HER2 hormonal positive HER2 negative breast cancer. And in this meta-analysis, we can see that the risk of recurrence in the first 3 years reaching 7%, and at 5 years about 12%. So this risk of recurrence actually remain there, and it is like accumulates over time. Early breast cancer classification also has been evolved from a population-based classification. Before we have only like staging, with the TNM staging also, we are classifying according to this, but the advances and evolvement lead to the addition of advanced clinical relevance like prognostic factors, which are clinically, and also we have a personalized, so advanced clinical personalized plus TNM classification. Now that is what we are using, and this is lead to personalized treatment and survival. Regarding those in hormone positive, HER2 negative, those factors, we have a high risk and low risk features. With regard to tumor size, we know that T3 and T4 are high risk features. Nodal status, specifically N2 and N3, grade 3, high Ki67, as mentioned earlier, more than 30%, regarded as a high risk feature, and low expression of the ER and PR receptors, less than 10%. Residual cancer burden is also after chemotherapy, neoadjuvant chemotherapy is one of the high risk features, and genomic signature, oncotype DX, which is MammaPrint and EndoPredict and PAM50, all these are used. We are using oncotype DX mainly, and this is can show us which are high risk or low risk. For the low risk, we have T1, node negative disease, grade 1, Ki67 less than 20%, and also a low risk class of genomic signature. For intermediate risk is actually defined in something in between the low and high risk. It may be like N0 disease with grade 1 and 2, or T2, T3, or grade 3, or we have T1C to T3 or N1 disease. So it is something in the middle, so we can define the intermediate risk group in this category. We can see that the risk of distant recurrence actually is positively correlates with the increased tumor size. And you can see here in this on the left side, for those with T2, so the risk of distant recurrence is higher compared to those with T1 disease. Nodal status also, as you know, if we have more than 3 lymph nodes, they have higher risk of distant recurrence compared to those with N1 to 3 or N0 disease. Recurrence risk also depends on the tumor grade. With the higher grade, like grade 3, they have a higher risk of distant recurrence compared to those with moderate and low risk. And also Ki67 is very important. Those with the low Ki67, they have a lower risk of relapse compared with those with high risk of Ki67. Recurrence also here depends on the, this shows actually the invasive disease-free survival comparing the high-risk group to non-high risk group. So classification of this risk stratification is very important to us to decide about our therapy. So I can conclude this here that those who have a high risk, here you can see stage 1, 2, and 3, and we can see that the risk of first recurrence after primary treatment is higher with stage 3 and stage 2, and those recurrent risk increases with endocrine therapy resistant, larger tumor, node positive disease, higher grade, higher proliferation index, which is Ki67, and lower ER and PR levels. Luminal B also increases the risk HER2 enriched and basal-like molecular subtypes. One of the important study is Monarch E study, which is using the CD4/6 inhibitors. And in this study, the use of adjuvant abemaciclib plus endocrine therapy in a high-risk node-positive, hormone-positive HER2-negative early breast cancer. And in this study, which is a phase 3 trial, which is international randomized open label, patient with a high-risk node-positive, hormonal-positive HER2 negative early breast cancer prior to neoadjuvant or adjuvant chemotherapy. Both of them are permitted. And for pre or post menopausal, definitely no distant metastasis, and less than 16 months from surgery to randomization. And there is two cohorts in this trial. The first cohort comprised about 90% of patients, and those have 4 positive lymph nodes, axial lymph nodes, or 1 to 3, plus positive axial lymph nodes plus histological grade of 3, and or tumor more than 5 centimeter. Cohort 2 is about 10%. In cohort 2, they use also Ki-67 more than 20%, and patient randomized to receive abemaciclib at this mentioned dose with 150 milligram BID, all and endocrine therapy. All they receive the standard of care of endocrine therapy, and stratification here done by prior chemotherapy and menopausal status and also the region. And the primary endpoint of this study is invasive disease-free survival, and there is other secondary endpoints, including overall survival and safety. And actually, in this trial, the primary endpoint, which is invasive disease-free survival, was met in favoring of adding abemaciclib to the endocrine therapy, with a hazard ratio of 0.73 and a significant p-value. And the duration of this treatment is for actually 2 years of abemaciclib treatment, and the patient after that will continue on the endocrine therapy. Looking to the overall survival, actually it met its critical boundary for statistical significance, and we can see here there is improvement with a hazard ratio of 0.72 and a significant p-value here. And according to this trial, this medication, abemaciclib, in addition with endocrine therapy, is approved for those patients of high-risk features, as mentioned earlier, as adjuvant treatment for up to 2 years. We have another medication, which is the same. It is a ribociclib. It is also CD46 inhibitors. And in this trial, also the same phase 3 trials for pre and post menopausal, but here they include stage 2, including those with node-negative disease. And also they include genomic risk profiling and randomization, ribociclib plus endocrine therapy versus the standard of care of endocrine therapy, which is aromatase inhibitor. The same primary endpoint and the secondary endpoint also more or less the same like abemaciclib trial. And this also met its primary endpoint with the improvement in invasive disease-free survival. And there is actually a trend towards improvement in the overall survival. And this medication is given for up to 3 years compared to the abemaciclib. And this is here you can show in node-negative disease also, because node-negative is a lower risk. So because in the previous study they did not use it, it also showed improvement in invasive disease-free survival. So when we look how to decide about giving the treatment in early breast cancer, we can see here for hormonal positive HER2 negative early breast cancer, for luminal A, which is mainly strong hormone positive with the low risk, the treatment will be only adjuvant endocrine therapy, depending on the menopausal status. For postmenopausal aromatase inhibitor, tamoxifen is an option, or giving tamoxifen and then aromatase inhibitor after that. And for premenopausal, tamoxifen will be enough, and the treatment duration should be like only 5 years, not more than that. When we look for the high risk group, even with luminal A high risk or luminal B, and the patients, they have the option to have new adjuvant therapy, and then After that, the adjuvant, they need to have aromatase inhibitor and tamoxifen. Duration can be up to 10 years. And for stage 3 or high-risk stage 2, CD46 inhibitor is very important to add, abemaciclib 2 years, and ribociclib for 3 years. So let us move to the HER2 positive early breast cancer. We know it is aggressive, but we have a lot of targetable medication. Mainly we are giving neoadjuvant for HER2 positive unless very small tumor. And we are giving dual HER2 blockade for the high risk. Adjuvant HER2, it depends on the result after pathology. If they have pathological complete response, we'll continue on trastuzumab or trastuzumab plus pertuzumab. If we have residual, we will give TDM1 here to complete 1 year, and the duration is 1 year. And now there is a new result of the TDXD compared to TDM1, which showed that TDXD is better than TDM1. So it will be the standard of care for those with residual tumor after neoadjuvant chemotherapy. So for those patients with low risk HER2 positive early breast cancer, you can see this APT trial. And in this trial, the adjuvant paclitaxel and trastuzumab for small tumor node negative. So we can give up to only 12 weeks of paclitaxel plus trastuzumab, and then trastuzumab to continue for total of 9 months. This is for a lower risk small tumors and node negative. For patients with higher risk, HER2 positive early breast cancer, we have a affinity trial which showed that pertuzumab and trastuzumab plus chemo compared to trastuzumab and chemo. And in this phase 3 trial, patients with HER2 positive early breast cancer and no prior invasive breast cancer or anti-cancer treatment, and not positive any tumor size, patient more than 1 centimeter, and then randomization to chemotherapy plus dual anti-HER2 blockade, or the standard of care at that time, which is chemotherapy with trastuzumab, the primary endpoint, invasive disease-free survival, and the secondary endpoints as mentioned here in the slide. And this is the primary endpoint for affinity invasive disease-free survival for node positive cohort and node negative cohort. And the main improvement here in the node positive group with a hazard ratio of 0.72, and the difference for the node negative is not significant. What about extended adjuvant therapy? Extended adjuvant therapy, sometimes we are using this narrative NIB. This is trial given after adjuvant trastuzumab in the HER2 positive breast cancer. And after completing the adjuvant trastuzumab 1 year, patient received neratinib or placebo. And then the primary endpoint was invasive disease-free survival at 2 years. And the primary analysis of 2-year rate neratinib about 93.9 compared to 91.6 for the placebo, and this was significant. And this is invasive disease-free survival for this trial. And also, this is for hormone positive and hormone receptor negative, and the benefit was mainly on those with hormone receptor positive. So we prefer to give this extended therapy for those with hormone receptor positive disease. This is the 5 years by patient subgroup, hormone receptor positive and less than 1 year from last dose of trastuzumab. So this is one of the neoadjuvant therapy for anti-HER2 treatment. And we have the pivotal studies of neoadjuvant trastuzumab, pertuzumab. We have a NeoSphere study, which use neoadjuvant trastuzumab and pertuzumab in those with chemo-naive women with HER2 positive breast cancer. And we have also the triphenea trial. And according to this trial, there is approval of giving the dual anti-HER2 trastuzumab and pertuzumab for patients with a high-risk HER2 positive early breast cancer as neoadjuvant, and after adjuvant we decide according to the pathological response. This is the trend, neoadjuvant chemo with or without anthracyclines with a dual HER2 blockade in HER2 positive breast cancer. And we can see here the primary endpoint, which was pathological complete response. There is a higher rate of pathological complete response with or without anthracycline, and the main outcomes consist across levels of pre-specified subgroups. You can clinically T stage and node negative or positive, hormonal, and by age also. This is a stratification. And this is the events-free survival, which show that there is no status, had a ratio of 0.90 when we compare that in giving anthracycline and regimen without anthracycline. Post-neoadjuvant therapy, I mentioned this. We have Katrina, which is trastuzumab, TDM1 versus trastuzumab after adjuvant, after giving neoadjuvant therapy, and then patient randomized to receive TDM1 or trastuzumab. Primary endpoint, invasive disease-free survival, secondary endpoint, distant recurrence. And according to this trial, which showed there is superiority of TDM1 compared to trastuzumab, trastuzumab was approved, but now we have what is called, I think, DESTINY-Breast05. They compare TDM1 with TDXD, and TDXD is superior now, and now it will become the standard of care. It's better than TDM1. This is the DESTINY-Breast05. I will not go on details on that, but this trial already, the results is out, and we have also adding TDM1 to catinib versus TDM1, but it still is not a standard of care. And this is early HER2 positive breast cancer, how to treat according to the risk stratification, if they need neoadjuvant, adjuvant, or limited adjuvant therapy like the 12 weeks treatment. Triple negative, the last things, actually, we know that it represents an aggressive subtypes defined by absence of ER/PR and HER2, and there is limited targeted options. They have a higher risk of early recurrence and visceral metastasis, and the current treatment, mainly we are giving neoadjuvant even for smaller tumors, chemotherapy with immunotherapy also for higher risk patients. Then adjuvant treatment like to continue on pembrolizumab. This is now standard of care for those who receive it neoadjuvantly. Those with residual disease, we can give capecitabine, and this is depending on the pathological response. And for both those with BRC mutated high-risk patient, we have also adjuvant olaparib to be given in those cases. For triple negative, because you know that the neoadjuvant enables assessment of pathological complete response is very important. And this is strongly, the pathological complete response correlates with the improved survival. And also, if there is residual disease, will identify patient for this treatment escalation. This is an important study, which is Keynote 522 study of immunotherapy, adding pembrolizumab to chemotherapy, and here for carboplatin and paclitaxel to be followed by cyclin base compared to the standard of care, which is without immunotherapy. And then after surgery, the patient continue on immunotherapy, continue in pembrolizumab, and the primary endpoint is pathological complete response. Other secondary endpoints, overall survival and safety. And in this trial, the pathological complete response in favor of adding immunotherapy compared to patients who did not receive immunotherapy. And this trial led to approval of pembrolizumab by all these regulatory authority, FDA, EMA, and others, as a new adjuvant treatment to be followed by adjuvant immunotherapy for this is the event-free survival of this trial, 15.7. This is versus 23. This is for the events, and you can see here clearly that the hazard ratio 0.63 and significant p-value. This is also by pathological complete response, yes or no, and you can see here those with pathological complete response and those without both of them, they are benefiting. So patients will continue having it as well. So this is for the treatment of early stage triple negative breast cancer. If like T1C node negative, neoadjuvant treatment should be considered, taxane, platinum versus giving less, and or if it have a higher risk like tumor more than 2 centimeters and not positive disease, we will add immunotherapy. And then after surgery, we will see those with no pathological complete response if they have wild type BRCA or mutation. If mutation, we need to add the PARP inhibitors, olaparib, for up to 1 year. If not, we will continue up year of pembrolizumab. And for lower risk, we can only give chemotherapy. After surgery, here we have capecitabine also can be given. So my take-home messages for my talk is that biology actually drive everything here. Hormonal positivity, HER2, and genomic profile are central to decision-making. Treatment is by subtype, as I mentioned. Neoadjuvant therapy is strategic tools. Actually, it enables the response assessment, the PCR, and it guides post-neoadjuvant escalation to give TDM1 or TDXD or capecitabine or PAR inhibitors. Avoid overtreatment in low-risk patients. No need to give these medications in low-risk patients. And we need to intensify therapy only when there is a clear benefit because of this toxicity of medication. Multidisciplinary care is essential. The optimal outcome requires MDT coordination with different subspecialty. And the future of early breast cancer treatment is not more therapy. It is the right therapy for the right patient. And by this, thank you so much.
Thank you very much, Dr. Amin, for the nice presentation. We will open the door for discussion and questions, so feel free, please.
Well, thank you so much, Dr. Amin. Actually, this is impressive. It's great presentation. Because always when we come to the subject, as a surgeon, of course, when we come to the subject of oncology, we find it difficult because of the evidence, because of trials, but you put everything together for the whole systemic treatment, which is great. Thank you so much. I might miss one point about immunotherapy for triple negative. What is the indication for giving immunotherapy in neoadjuvant, both neoadjuvant and adjuvant setting, when we give immunotherapy for triple negative cancer patients?
Okay, actually, this is mainly for those with a high risk, feature. And in this study, actually, those like with not positive disease, yeah, if it is like small tumor like T1 disease, they need to have not positive disease like N1 or 2, or they have like T2 to T4 disease with node negative. So those are with high risk feature, not all patients. So if it is a smaller tumor, we need not positive disease. With the larger tumors, we need like T2 to T4, N0 will be okay. So this is for high risk features. And then the treatment will be giving the immunotherapy concurrent with the chemo. And then after surgery, the patient will continue to complete up to 1 year of pembrolizumab.
Is this apply for adjuvant setting as well? The same criteria to give them for adjuvant setting as well?
No, for the adjuvant setting, if I give the pembro in the neoadjuvant, I will give it in the adjuvant. If I did not give it, if it is a low risk, I will not give immunotherapy here in the neoadjuvant. So definitely in the adjuvant, I will not give. So the criteria from the beginning, I need to decide about it.
No, because if, for example, we found lymph node positive post-operative that we didn't detect pre-operative, so they put them in the high-risk group. So this is indication. I mean, what is the indication for adjuvant setting for immunotherapy? This is my question in better way.
The indication here, those patients, they receive it in the neoadjuvant setting, I will give if they receive it. But if they did not, this study actually, your point is very valid, but this study did not address this issue. If after the neoadjuvant therapy and I upgrade the stage by not positive, so I will give immunotherapy. No, the decision will be from the beginning. If I decide it is immuno, I will give. If I did not decide, I will not give immunotherapy post surgery, even if it is a high risk, unless we have study to address this.
So this means they are under-treated, this group of patients, that we missed something before operation.
Maybe, but most of the time, clear. You are right. Sometimes you have you are doing sentinel lymph node. It is node negative, and then you will find it is a positive. So in this case, in this case, we will go to other adjuvant regimens, and we have the capecitabine, which is Eloda. We can give it to those with residual disease. So it is indicated in this case specifically. Your case, when you mention you upgrade the staging by node positive. And also we have the PARP inhibitors, which is for those with BRCA. For those with BRCA mutation, definitely not for all, for 1 year.
Okay, so I think we need another trial for this group of patients.
Yes, definitely. Maybe there is trial going. I'm not aware about this. Maybe there is something addressing this issue also.
Yeah, thank you.
Welcome.
And I think there is a question, Hussein raised it early when he has presented new adjuvant endocrine treatment, because the question about giving letrozole instead of another non-steroidal anastrozole or exemestane. Is there any trials, because he asked this question, is there any trial confirms that letrozole is better aromatase inhibitor than the others or no?
What do you mean others? Than anastrozole?
Anastrozole and exemestane.
Anastrozole is like letrozole. There is no study show that letrozole is better than anastrozole. There is no study. This is for the aromatase inhibitors. For tamoxifen, there is a study show that aromatase inhibitors is better than tamoxifen, especially for
all of them. All of them.
But we know, and even for the new
letrozole is strongest non-steroidal aromatase inhibitor in all of them. I mean, compared with anastrozole.
Yes, we are using it. Yes, actually, we are using only letrozole, but I am not aware about the study they compare anastrozole to.
Me too, because he asked Hussein early this question, so there is no study.
Yes.
Thank you.
But for tamoxifen is less than aromatase inhibitors in general, and even for those, you know that for premenopausal, we will do ovarian function suppression, and then we will give them the aromatase
inhibitor.
Yes, especially for the high risk, even patients like we have patients, their age like in their 30s, we are giving them ovarian function suppression, and we are giving them aromatase inhibitors because it's better than giving tamoxifen.
Stronger. Thank you.
Welcome, Dr.
So thank you again, Dr. Amin. Dr. Nahla, are you ready yet?
Yes, I'm ready. Thank you.
Okay, next we stay with Dr. Nahla Jaffer, MD consultant oncologist, Khartoum Oncology Hospital, researcher, King's College London, Vice President for Aortic. In management, update on oncology management. Please be our guest.
Thank you. Sorry, my session is about long-term sequel of early breast cancer treatment because the topic, the main theme is early breast management. So I'm going just to go ahead with what Dr. Amin mentioned and what are the long-term sequel for early breast cancer management and how we can mitigate these side effects and complications. Good. So it's very important, and as Dr. Amin also said, we need to avoid overtreatment and to and allow it at lower for low risk patients. Avoid overtreatment for low risk patients. This is very, very important, and we need to understand that the side effects that patients have are, we can divide them into two. We have the acute, the early ones, and we have the late sequel. And most patients who have late sequel are unfortunately lost, forgotten. Patient comes with early breast cancer, she received surgery, she received some adjuvant treatment, and then after 10, 15 years, she develops cardiac disease. And nobody is linking the reason or the issue. So we need to think about the side effects, especially those long-term, those complications. Sometimes they are not so frequent, but they are very important because they affect so much, not only the life of the patients, the survival, but also the quality of life. Good. So the first one I'm discussing here is about chronic pain and neuroma formation. And this is very common, and I think the surgeons and also the oncologists meet these patients who say there is still pain in the site of surgery. Okay, it's so much under-recognized. We need to ask about it. We need to give them management for it, sometimes massage, pain medication when there is this sharp pain when it happens. Even paracetamol can help sometimes, but also gabapentin and pregabalin. Okay, as for surgical neuroma, this one needs management excision. The neuroma, it needs surgical excision. Good. Another one is axillary web syndrome. We ask the lady to extend her arm, and she says, I cannot raise it more than that. Okay, this is very common, 20 to 50% after axillary dissection. And of course, that's why we always prefer lesser invasive surgeries, better, more frequent sentinel biopsies if possible. And it is the palpable cord from the axilla to the wrist, and it causes restricted shoulder and elbow extension. It is not a blood clot. We need to reassure them that it is not, it is benign but treatable. And the best management is early movement. And the surgeons with us, I think their work extends beyond the operation room. In their follow-up, they ask the patients to do these wall walking exercises from day 2. Okay, that also helps to prevent them. Good. And then we have also the lymphedema. Okay, this is a lifelong complication. And also the same, we need patients to mobilize the arm. And I remember the first time I was a registrar, I was Prof. Hussein Mohammed Ahmed, Allah yarhamu. I was there with his in his clinic, and he told the lady, let's do this exercise. So he did the exercise with her. And now as I went into the field of palliative care, and according to the degree of the lymphedema, we have 4 interventions we do for the patients. One of them is the exercise. So if it is already there, like there is lymphedema, the patient has to exercise twice a day, in the morning, in the evening, and it's going to be like 10 times, raising the hand 10 times. Second step is elevation of the arm. So whenever she is there, she just needs to raise her arm above her chest. Okay, so we will just want the lymph to flow back. Third one is massage, but a certain way of massage. The arm is already lifted, and we start from the peripheral part, and we press deeply, and we go down till the axilla. And this massage can be done like once a day, okay? And it's not, sometimes they say, we do like this very softly. Instead, this softly one increases the lymphedema. But what we want with the hand, they press till they reach the bone and they go down. Okay. And the fourth one is what you call it. We bring something soft like a veil, very soft veil, and it's compression. So we just make a compression, leave it for some time, for after 3 minutes, 5 minutes. It's a little bit painful, so you can release it again. So these are the 4 procedures where we do for patients who have some degree of arm swelling. If there isn't the arm swelling we want to prevent, we do just the exercises. Good. And then we have brachial plexopathy. I haven't seen it in my patients. It's rare, less than 1%. And it used to be 2 to 5%. So it's progressive motor weakness and sensory loss and pain in an ipsilateral arm, months to 2 years after radiotherapy. And we can do some investigations like MRI to make sure that there isn't recurrence, and treatment is supportive. Best way is to prevent it, conformal radiotherapy. Okay, make sure the brachial plexus dose is less than 60 gray. Another late side effect for radiotherapy is cardiac toxicity, and especially on the left side. Okay, it increased the coronary events 1.5 to 2 times after 10 years, and pericarditis 1 to 2%. So we can have pericardial constriction, myocardial fibrosis, valve disease. Of the ways to mitigate it is the deep inspiration breath hold, DIPH, proton therapy, and make sure the mean heart dose less than 4 gray. Management, of course, for us, we just send them to the cardiologist. So we need to do the surveillance, echo every 3 to 5 years. And if there we have change, we send the patient to the cardiologist. Make sure also that they do good control of their blood pressure and lipids. Good. And then we have, it is rare, but it is still there, the secondary lung cancer, okay, from the radiotherapy. So the frequency is 0.5 to 1% at 10 to 20 years, and it's going to be higher in people who are smoking, so we expect we don't have a lot of our Sudanese ladies who smoke. And there is radiation-induced lung fibrosis. Okay. The mitigation is reducing the dose to the lung. Okay. The volume 20 less than 20% for whole lung, and smoking cessation. And follow-up with CT scans. What you call it, screening, annual low-dose CT scan after the age of 55. We come now to endocrine therapy, osteoporosis, and atypical fractures. Okay. Aromatase inhibitors lead to bone loss, 5 to 8% over 2 years, and fracture risk about 1.5 and 1.6. Complication, atypical femoral fractures. This is rare, 0.1%, especially if we are giving patients biphosphonates. Mitigation, we do baseline DEXA, calcium and vitamin D, and biphosphonates if T-score is less than 2.0. And management, switch from aromatase inhibitors to tamoxifen if we have bone loss, which is progressive, and we can stop the denosumab after 3 to 5 years. Endocrine therapy, another one, endometrial cancer. 2 to 3% increased risk, absolute rate 0.5 to 1% over 5 years. We have endometrial hyperplasia, we have carcinoma. I have seen a few patients who developed secondary endometrial cancer after their treatment with tamoxifen. So while the patient is receiving the tamoxifen, we check. We need to involve the gynecologist. We usually forget that, but we need to do images for the uterus, and we involve the gynecologist. And most important, even the education of the patient. If you have any suspicious bleeding, come, let's check, okay? And the thromboembolism is also an issue. It's 1 to 2% over 5 years. For aromatase inhibitors, it is less. Post-thrombotic syndrome. And mitigation, we avoid tamoxifen, especially if the patient has got previous venothrombic embolism, thrombotic phenomena, and consider aromatase inhibitors or anticoagulation. Okay. Treat them with direct oral anticoagulants, switch to aromatase inhibitors for future endocrine therapy. Another thing is the chemotherapy-induced peripheral neuropathy. Okay, that's especially from taxanes. We have 30 to 70% acute and 10 to 30% persistent. And I remember I had that very nice lady. She completed her treatment, but she comes with her husband and she says she has pain. And I couldn't believe her when we were giving her pain medication. And then she said, no, it's not, it's still painful. And we changed, we gave her opioids. And I think I sent her to the neurologist at the end. It can be very serious, very life changing, because they can do nothing with this severe pain. Some of the late sequelae for chemotherapy-induced peripheral neuropathy are gait impairment, increased falls, neuropathic pain, reduced fine tumor skills. Mitigation, cryotherapy during infusion, and especially limit the cumulative dose. I think monitoring and limiting the cumulative dose is the most practical one. And we have duloxetine. We have good evidence for it. Physical, occupational therapy, and avoid opioids as first line. So it's not always responding to opioids. Another long-term anthracycline-induced cardiotoxicity. So these patients have heart problems from radiotherapy, from the chemotherapy, especially anthracyclines, and then we will see later from the targeted therapy. So we have subclinical LVEF drop, 10 to 20%. So it's very important to check the left ventricular ejection fraction before starting chemotherapy and after, or let's say every 3 months while they are doing their chemotherapy. We need to check that we don't reach the cumulative dose for doxorubicin or ibuprofen. And we need lifelong cardio-oncology follow-up. Okay. So it will be like echocardiogram every year for at least 5 years, and then every 2 to 3 years. If left ventricular ejection fraction drops below 50%, we need to send them to the cardiologist to start treatment. Then secondary myelodysplasia, okay, or leukemia, okay. So this is the risk 0.5 to 1% at 5 to 10 years, and so very important to avoid unnecessary chemotherapy and use GCSF judiciously. So this combination of the chemotherapy, the GCSF factors might increase the risk for secondary myelodysplasia. If it happens, it's a little bit complicated to manage allogenic stem cell transplant, but the thing that we can do is the supportive care. Okay. So these patients will develop unexplained anemia, bruising, recurrent infection. Okay, and we need to check a complete blood count, and peripheral smear is for diagnosing the situation. Another long-term sequel of chemotherapy is the ovarian failure. And unfortunately, I find this one we are very missing in our discussion with patients about it. We have to be very clear, especially with young ladies. We have to speak about the premature menopause that can happen. We need to speak about the fertility issues, their plans for families. If they want to get married, they have family and number of children. This is very important, and we don't want that the patient completes the chemotherapy and then they ring and say, "Oh, the cycle never came back." That is not good. We have to speak about it earlier on, and we have to understand that if the lady is near to her menopause, it is more likely that she will have the cycles are not coming back again. If she's younger, her cycles might return after stopping her treatment. And then might be you have heard about it, chemo brain. Sometimes we think it is psychological, but it has a scientific basis. It has a frequency of 20 to 50%, especially during or after the chemotherapy, and it is persistent in 10 to 20% of cases beyond 5 years. So there is impairment of executive function, there is memory loss, also deficit in processing speed, mitigation. So we need to assess before the chemotherapy, the cognitive assessment, the physical exercise during treatment, but also we need to do cognitive rehabilitation, like teaching skills, using calendars, lists, alarms, okay? So anything that like activates the mind, even for those who are reciting the Quran and they memorize it. So recitation, it also improves or reduces this important side effect. Then we have the HER2 targeted therapy. We can have also persistent cardiac dysfunction. So check these ladies who are receiving radiotherapy and chemotherapy and trastuzumab. Okay, this is very serious. So this one is they have happens after 6 months after stopping treatment in 1%. This is good news that it's not so frequent, but it is serious. Chronic heart failure. They need lifelong cardiac medications. And the mitigation is that we check before starting the treatment, left ventricular ejection fraction. We monitor every 3 months. We hold the treatment if the left ventricular ejection fraction went to less than 40%, or we have a drop of 10%. Okay. We resume the treatment after the left ventricular ejection fraction returns to more than 50%, or we think about alternatives for continuation of the management of the patient. But usually patients recover within 4 to 6 weeks. Okay. If we stop it for 4 to 6 weeks, then they can resume again. And then we have for CDK4 or 6 inhibitors, long-term neutropenia and infection. So this one causes profound neutropenia, rarely fever or we do not give the GCSF routinely, but it does reduce febrile neutropenia at risk and may cause bone pain. Instead, hold the drug until ANC recovers above 1,000, then restart at a lower dose. I think this one is more of early, but yes, it still has late sequel. And permanent immunotherapy, permanent endocrine defect, hypothyroidism, 10 to 15%, adrenal insufficiency, 2 to 4%, type 1 diabetes, 0.5 to 1%, lifelong hormone replacement, risk of adrenal crisis. So immune checkpoint inhibitors, they can permanently destroy the endocrine glands, and thyroid failure is the most common. So we need to treat with levothyroxine. We can also have adrenal insufficiency, which is dangerous. And type 1 diabetes, they can present with DKA in 40% of cases. So we need to monitor glucose with every cycle. So this is the plan. So for every patient who completes treatment, they should leave with a written document about survivorship care, and which we list the treatment that they received, the risk for late side effects, and what is the plan for follow-up. We need to empower the patients to be partners in their long-term health. So we need to explain to them what are the signs so that they come back, not to wait. So we need to detect these late effects as soon as possible in order to prevent disability and in order to save lives. Thank you so much.
Thank you, Nahla. Thank you so much. This is a great presentation, very informative, and really quite practical points as well. Thank you so much.
أنا وصلت، معلش كنت بعيدة في الطريق لكن وصلت البيت. السلام عليكم. والله
عليكم السلام.
زعلانة إنه الليكشرز فاتتني، لكن أهو.
It's all right to wrap up. At least you finally joined. فالحمد لله قدرت اتصلت عليه. بعدين مسجل المرة دي فإن شاء الله you can catch your face.
الصورة أهم حاجة. أهم
أوكي.
حاجة المجموعة تاخد لقطة مع بعض،
طيب
مهمة جدا.
نحن ما شايفين غير نظارتك دكتور رباب.
يعني هتجوز. طيب كده كيف؟ كده كيف؟
كده شايفين النقاب.
كويس. نكلم الناس التانيين يفتحوا الكاميرات بتاعته.
أيوة
ايوه خدوا لقطة وبعدين
نشوف.
نقول كلمة الختام.
تمام، ممكن بس نشوف لو في أي questions، في أي addition.
ايوه افضل.
ده اسال دكتور امين البلان بتاعهم للسرفايفرز، يعني هل في بلان معين بيعملوه في الهوسبيتال، يعني حاجه كده ستاندرد؟
ليه الكاميرا دي لا؟
general in the past. Now I am working in Medina. Medina, and our department is smaller compared to when I was in Riyadh. And have
الصوت
here,
مقطع معلش.
this is actually we are referring. Are you hearing me? Is it okay?
Yes.
No.
صوت رجع حاليا بس.
Okay. So in Riyadh before we have a survival clinic. This is we are referring all patients to this clinic from different actual cancer types, especially breast cancer. After they completing their adjuvant treatment, whatever, if it is 5 years, you know, in the past we are giving only 5 years of hormonal therapy, but now we are extending more. So if the patient completing their hormonal therapy, so we'll refer them to the survivor, or we are depending on the primary or family physicians to take care of this follow-up, like doing annual mammogram and following also for sometimes toxicities according to the treatment. So this is. But now we did not have like a clinic to follow up our patient. I think in UK, I want to speak on behalf of them. So Ramona can comment.
Yeah. Lion, we're cutting off, Dr. Amin.
The GP maybe.
Yeah, I can speak about. Nahla, can you hear me?
Yes.
Dr. Amin, we cannot hear you. I think, yeah, it's great presentation.
I am hearing you.
Yeah, you can talk now because you lost you a few minutes
okay.
ago.
No, I mean, I said that maybe you can speak about UK more than me regarding those patients will be referred to the GP, so they will follow up with the GP, not with the oncologist or something like that.
No.
This is for those who survived like 5 years or something.
Yeah, Nahla, we got, yeah, as I said, it's great presentation, practical point, and is excellent. And this complication or risk, some of them is preventable. So always prevention is better than cure. So the one we can control, we can prevent, is better to work on that. In UK, what we will do routinely, pre-operatively, neoadjuvant systemic treatment, pre-adjuvant systemic treatment, there is a specific nurses, which is the breast care nurse, or what we call Macmillan nurses, which is a cancer nurses. They sit with patient, especially for the complications that we can prevent, like shoulder lymphedema, arm lymphedema and shoulder stiffness. We got like a lot of leaflet in information patient take home, and usually they follow this, and usually they got a phone call frequent. So this is the importance of multidisciplinary approach in treating the breast cancer patient, because you can't do everything yourself. You have to rely on other disciplines. So the breast care nurse, they do great job. The cancer nurse, they do great job. They follow the patient. But in terms of follow-up, we use in our center, we used to see them the first 2 years and then discharge them for just mammographic surveillance for the last 3 years. So in total, we keep an eye on patient for 5 years. But we change the system a bit now. So we introduce what is called patient-initiated follow-up program. So the patient, they got an access, open access, because they got too lazy to go to the GP to be referred to secondary care again. So any cancer patient, they got what is called patient-initiated follow-up program. It is open access to the service for 5 years. So if the patient concern whatever, swallowing, any concern, so just to call and we'll bring her for assessment. And every year she's going to have mammographic surveillance to finish the 5 years. So this is the way we work. Generally, yes, I think most of UK departments, they got away. Like I work in some units, they do what is called survivorship follow-up, which is the nurses. They choose the patient every year to go through everything. The system is different, but still will keep them under follow-up, not with oncology, with the surgery. Just in case they need imaging, they need whatever, usually, yeah, they come back to us as a surgeon. And some patients, yes, high risk of recurrence, usually they stay under follow-up with oncology as well.
Good, thank you. Dr. Rabab, you remember our clinic when you visited us in Khartoum Oncology Hospital? I'm not sure where she went. But in that hospital, I had several people. I was the head of the unit. It was a palliative care and oncology unit. So I had some staff. For example, I had the registrars. The registrars are the patients who see the patients and write the chemotherapy. I have a very competent medical officer. This is lady seeing the she's trained in palliative care, so she sees the end-of-life cases and like this. But all the staff were trained in palliative care and very efficient in improving quality of life for patients. So we had the nurse. The nurse was seeing the patients who are on hormonal treatment or who completed their treatment. We never stop seeing patients, but we see patients usually like every 6 months, I think, in the first year, and then once a year, then every 2 years, and then once every 5 years. And these we make use of these patients. Sometimes they come and they already have their own hair grown up and living a normal life. And then we have a lady who doesn't like to take chemotherapy, or she refuses surgery. So we make use of them to discuss with them and tell them. You remember Dr. Rabab, our clinic?
الحين انت جيت راجعة هبطت شوية كيف الله يسلمك. قلت لي شنو؟
تعبناكي معانا الليلة.
لا العفو والله، بس أنا كنت ما موجودة، كنت شغالة. عرفتي يا داب جاية راجعة فاكزوستد ومهبطة شوية. فقلت لي شنو؟
تذكري محاسن النيرس بتاعتنا مدربة في البالياتيف كير، فهي اللي بتشوف البيشنتس اللي بياخدوا هرمونال تريتمنت.
الام دي تي كلينكس.
ايوه الام دي تي كلينيك. وزيادة عليها نحن في الوحدة بتاعتنا مقسمين كل الكاتيجوري، كل زول بيمسك حاجات معينة. فأنا بشوف مثلا النيو كيسز، لكن محاسن بتشوف البيشنتس اللي كملوا التريتمنت بتاعتهم وبتناقش معهم حاجات كثيرة منها سوشيال وسايكولوجيكال. بس examination تعمل لهم examination، تعمل لهم الانوال انفستيجيشنز، وبتتكلم معهم برضه لو حصل كده. يعني مثلا عندي patients بيكونوا بياخدوا long term biphosphonates، اوكي، وعندهم bone metastasis، و maybe we don't need to give them other treatment. فبنوريهم انه لو في severe pain في الباك، مثلا بيكون عندنا الهول بودي بون سكان، عندنا very clear انهم عندهم metastasis، لكن بنوريهم لو في severe bone pain اتصلوا طوالي، نديهم رقم تلفون ويورونا. اوكي، لو حصل weakness في اللور ليمبس برضه المانجمنت للسايد افكت.
لا نتذكر يعني ما شاء الله عليك. كان عندك سيستم من ما في اساسا، ما في سيستم، لكن كنت عامله سيستم. ربنا يتقبل.
ومره حصلت انه الدنيا كانت عيد، اتصلوا عليها على السيستر، قالوا لها المريضه عندها الم شديد في رجلينا وما قادره، يعني الم شديد في ظهرها وما قادرة، يعني الحركة ضعيفة، رجلينا بقت ضعيفة ما شايلينها. فتخيلوا إنه السيستر مباشرة طلبت منهم ياخدوا هاي دوز ديكساميثازون، واتصلت قالت لهم تعملوا الMRI، واتصلت على الدكتورة في المستشفى، كانت شغالة راديوثيرابي في اليوم داك. طبعا احنا كانت دكتورة رضية، فحجزت معاها، حنستها إنه لازم تدخل البيشنت دي وهي emergency وكده. وفعلا she saved the functions بتاعت lower limb والpatient alive well mobile. فالtraining للother staff members very important وبيساعد.
دور.
Thank you. تحية خاصة لأخونا عمر الفاروق. السلام عليكم يا عمر.
رباب اقلب الكاميرا بتاعتك. ظهر لنا بالجنب.
ايوه
كده بلقى نفسي لها، فما ظاهرة عندكم معتدلة.
كده كويسة، كده معتدلة.
انا عندي شايفه روحي كده لافه بالجنبه، عشان كده
لا لا، كده
قلبتها
كده كده كويسة معانا.
كده فيسنج يو عديل كده.
أيوه.
بالله
أي
سبحان الله. يلا انا لما اعاين كده حاساها يعني شايفه نفسي قدر ما الفت روحي كده القى نفسي looking، يعني مدياني الكاميرا اني looking to the right. فلما اقوم اقلبها كده بكون فيسنج يو عديل.
لا لا،
تظهر
كده أنت
عندكم العكس.
هوريزونتال. أنت أيوه، أنت كده مقلوبة. كده كويسة.
سبحان الله. طيب طيب طيب، ما دام كده الكوريكت اتس اوكي.
خلصنا يا جماعة وفينيش.
شكله كده ناخد صورة.
طيب،
انا خلاص يعني في زي ما قالوا فضلت حتة صغيرة. خلاص هبطل.
ما ترهقي نفسك دكتورة ربابة. لازم البريك، لازم تهتمي بنفسك أهم من الشغل.
آه، يلا. لا، ما
كويس.
ده مهم برضو يا نهلة.
مين
ليه
بيقدر
وقع
يفتح الكاميرا؟
ليه وقعوا
anybody more؟
تماضر زي مش كده تماضر ممكن. قول
لا
لهم كله يلا الجروب الموجود قول لهم افتحوا الكاميرا.
هاي
المرة دي انا ما معكم بينك، طلعنا من بينك
ابتسامة.
اكتوبر.
دكتورة نادية تقدري تفتح الكاميرا؟ دكتور غسان، دكتور عمر، إسراء. أيوة. وينك يا دكتورة نادية الآن؟ صوتك you're muted.
ألمانيا.
أوكي. لا، ألمانيا بعيدة، أنا جاي لك في مصر.
في ألمانيا.
كويس، ناخد الصورة. ابتسامة.
مستر عمر ما شايفينه. محمود. إسراء. غسان برضو.
إسراء.
1 2 3. مرة أخرى. 1
طلعت
2
معتدلة
3.
مقابلاكي ما منفوتة
يا انتي
بالجنب هنا
معتدلة.
متأكدة.
معتدلة. ودقيقة أنا أصلح الكاميرا عشان الناس كلهم يكونوا حجمهم واحد. كده تمام. يلا. 1 2 3. ابتسامة، دعنا نشوف السنون. ثانك يو.
أنا مبتسمة كمان. أنا كمان
انت
مبتسمة. ما شفتي الابتسامة بتاعتي؟
لازم تورينا انك
ما
مبتسمة ولا
شفتي؟ لا
لا.
لا ما شفتيها في عيوني. الابتسامة بتظهر في العيون.
ايوه صح. تاني. 1 2 3. كويس. انا
كلهم
حنبتدي ليك.
ظهروا كل
مستر
ايوه
عمر
ايوه
ما
ظهروا.
في. مستر عمر
ما
ما
في
في.
ناس
إسراء
قافلين
ما في.
الكاميرات، نعمل لهم شنو؟ ما في
ناس
حاجة
قافلين
نعمل
لا
لهم.
لا
الكاميرات.
دكتور عمر نادوا عليه مهم يعني ما من الناس اللي قدموا في الأول. ها مستر غسان ظهر لكم قبل انتوا ناديتوا على مستر عمر ومستر
آيتي
غسان
دكتور غسان. غسان فاتح الكاميرا.
ودكتور أمين
امين فاتح. ايوه.
أنا معاكم.
والباكستاني
لا لا، مش
مشى.
قبيل اعتذر. يا الافغاني اعتذر.
أفغاني هو.
مم.
كان تصوروه طوالي كان في وقتها تاخدوا صورة يلا قدر الله. أنا
ما
كنت
مشكلة.
بيزي بس.
بيحضروا تاني معاكم ان شاء الله.
إن شاء الله مرحب بهم.
لكن عجبني فيهم انه في نفس المستشفى. وانا زرت كم مدينة، زرت مدينة كندوز، مشيت كابول، وفي مستشفى اسمها علي عباد.
مشيت يا
اول حاجة
شنو
عندهم
يعني؟
مساحات.
شرتي بس ولا شنو يا نهلا؟ شكلك عارفة
تبع
الحتة.
منظمة الصحة العالمية. انا طبعا displaced، انا بقيت لاجئة في مصر. فبالصدفة
الريكوردين عشان نقدر بعدين نواصل في الونس عادي. ف فينش مش كده، ما في كلوجر. دكتورة رباب لو عايزة تقولي أي فاينل وورds قبل ما نقفل الريكوردين بعدين ممكن نواصل دكتورة نهلة. سوري.
ما وكلتك أنا في إكزوستك نفسي جاي ما حقدر أقول لك كلمتين ورا بعض.
طيب.
قوليها.
والله أنا لا ما لحقت يعني. أنا لا فاينل مينيت بلان دي
كملي 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 بس الباقي من لما تحسي إنه الباقي ما هنا كملي من عندك بس.
طيب تمام. أنا alright تمام. هي صراحة words من دكتورة باب، فأنا بس حقرأ on behalf من دكتورة باب. هي expressing her gratitude for this great work. So, thank you, everyone. It has been an incredible journey in those 2 days of the symposium, of the fourth radiological breast cancer symposium that hosted by the Sudanese Society of Breast Imaging and Women Health. And it has been a virtual gathering over those 2 days, recording the activities retrospectively from October 2025. And it's really a great gratitude and
ممكن تختصريها عادي.
like, okay, I'm just trying to write the words.
Yeah.
Like warm and sincere gratitude for all of you for attending, presenting, and dedicating this time, and also enriching the discussion has been really wonderful. And Dr. Abba for sure, Dr. Hiba, Dr. Isra, has been really incredible work and wonderful. So thank you all, and thank you on behalf of the Society of Sudanese Breast Imaging and Women Health, and hope we keep this work, and every time we add more and make it like something regular in the future. Thank you.
Thank
Thank
you,
you.
Rabab. Thank you, Rabab, for organizing. Thank you for putting all of us together to do this work and to help our people in Sudan. يعني في ميزان حسناتك إن شاء الله يا رب العالمين.
وحسناتكم جميعا، يعني انتوا كمان ما قصرتوا، استجابتكم طيبة.
لا والله ما شاء الله excellent يعني excellent conference excellent meeting صراحة very enriched يعني a lot of presentations.
الله يكرمك، الله يكرمك، الله يكرمك يا رب. This is the fourth one for the society. وإن شاء الله we'll continue. إن شاء الله ربنا يقدرنا، ربنا
معكم على
يقدرنا.
طول إن شاء الله، معكم على طول
إن
ما
شاء
شاء الله، موفقين إن شاء الله دائما.